and also Dr. Saujanya, Fernandez Hospital, Hyderabad. The session is chaired by Dr. Nelby George. The session on pediatric surgery is dealt by Dr. Abraham Aman. He is the HOD of Pediatric Surgery, MIMS Calicut. The session is chaired by Dr. Nandakumar, Senior Pediatrician from Kannur. About X-rays, the session is dealt by Dr. Krishna Mohan. He is from Calicut. I should say very close associate, our club. If I am saying that he is wedded to Wayanad Club, it may not be it might be really true because his wife is from Calcutta. A very close associate of our club. He is the chairperson of IAP Respiratory chapter. The session is chaired by Dr. Suresh Kumar, HOD of Pediatrics, MIMS Calicut. So these are the programs and the projects and the talk which we have arranged. My most sincere welcome to all the dignitaries, all the faculties, and all the chairpersons. So also my sincere welcome to our Vijayan, our president, our own president, our most vibrant secretary, Dr. Yashwant Kumar, and our treasurer, Dr. Nimmi. I don't know whether I have omitted anybody. I am extending a very cordial welcome to all the senior members, presidents and members of all other clubs who have joined here in good numbers, senior colleagues, past office bearers of IAP, our own members, Dr. Jason, Dr. Narayanan, all the seniors. I am extending a very cordial welcome. Last but not least, Vishnu. He is the person actually for coining the faculties, for selection of topics, and also for drafting the what is it called? Our program, even in drafting our program. With these few words of introduction, let me conclude and wishing you all the best. Thank you very much. Jai Hind, Jai IAP.
Thank you, Madhu sir, for the welcome address. Now I invite our President of IAP Kerala, Dr. T.P. Jayaraman sir, to deliver the presidential address.
A very good morning and a very happy Independence Day on the 75th anniversary of Indian independence. Respected organizing chairman of the day, Dr. Madhu sir, chief guest of the day, Dr. Sachidananda Kamath, President IAP Wayanad and my classmate, Dr. Vijayan, National Vice President and my co-PG in ICH, Dr. Somasekhar, Dr. Narayanan, Dr. Vijay Kumar M, President-elect, Dr. Johnny Sebastian, Secretary, Dr. T.V. Ravi, National Neonatology Forum State President, Dr. Manoj, Executive Board Member of National Neonatal Forum, Dr. Jason Unni, Dr. Riaz, Dr. Nandakumar, CAP EB members, Dr. Balachandar, Dr. Yashwant Kumar, senior members of the IAP Wayanad, Dr. Surendran sir and Dr. Narayanan Nair sir, all the other dignitaries on the platform. After a long waiting, summer Pedicon has come to us as Monsoon Pedicon, and I congratulate IAP Wayanad for the effort they have taken and arranging such a conference with meticulous selection of topics as well as speakers. Actually, we used to have the summer Pedicon, the sessional conference in every May, and due to various reasons, already explained by Dr. Madhu sir, this had to be postponed to this August, and the team Wayanad has arranged it in such a good way in a short notice. I like to mention a few things like, our action plan for the year has progressed very well as planned, and we have almost completed. Every action plan has been initiated and it is going in a good way, though on a virtual platform due to COVID limitations, we were not able to conduct the workshops we planned. And most of the programs have got the due recognition as well as appreciation from the pediatric fraternity of the state. I am very happy that all the action plan coordinators are doing the very best. And especially to make mention of the breastfeeding and mother and baby friendly hospital initiative, IAP Kerala could make a big impact on among the pediatric fraternity as well as the doctors, hospitals, and the community regarding the importance of breastfeeding. And we were able to force the government to institute a program for recertification and monitoring the baby friendly hospital initiative. We all of us in IAP Kerala has to be proud of this achievement, and I thank all of you and especially Dr. Ananda Keshavan, who was on the forefront of the program right from the beginning. Again, it was one of the great things that actually yesterday IAP Kerala was invited by the government of Kerala to check out the programs uh, to give the pediatric priorities for the next 4 or 5 years. And we had attended along with Dr. Sachi and Johnny, and few of us had attended a very important meeting with the government uh, in evolving the strategy to finalize the priorities on child health front for the next few years. And this, I feel, is a great recognition which IAP Kerala obtained from the government of Kerala. And one of the important action plans for the year, two of the important action plans, like bridging the gaps in immunization as well as the trauma protocol, government has agreed to take up in a big way as part of the government activities in the coming years. And we are scheduled to have a few more meetings in this regard at the micro planning level with the government. So I feel this IAP Kerala can be proud that our opinions are being taken with the due importance by government of Kerala. And on this occasion, I want to convey this happy news to all of you. So with this, I wish the very best for the coming CME as well as the organizers and for the faculty and for this conference. And once again, I thank you for arranging this at a short period in a wonderful way. And thank you for inviting me to participate in this function in the capacity of IAP President Kerala. Thank you so much.
Thank you, Jayaraman sir, for the presidential address. It's my pleasure and privilege to invite before you our chief guest of the day, Dr. R. Somashekar, Vice President, South Zone Central IAP. Sir, I request you to inaugurate the program and share a few thoughts.
Very good morning to all of you. Respected our President, Academic Guru, Dr. Piyush Ji in absentia, the immediate past President, our visionary President, Dr. Pakul Jayan Parekh Ji in absentia again, and our President-elect and ever-dynamic, energetic, charismatic President-elect, Dr. Ramesh Kumar Ji, and our Honorary Secretary General and live wire for all of us, Dr. Vasavaraja in absentia. All of us know that they are very busy in the ECD physical TOT at Hyderabad. And I always feel homely whenever I come and to IAP Kerala. So today is a very national day, very special day to all of us. And it is a national festive day. All of us are in a Josh mood that we are celebrating something which we are going to have a celebration in our own house. So it is today is this 75th Independence Day. So on this day, the IAP Kerala and the IAP Wayanad hosting a very important event, that is the Monsoon Pedicon 2021. So it is being hosted by a very hilltop Wayanad branch, that is a very vibrant branch, have organized this Monsoon Pedicon. So at this juncture, my hearty congratulations and pranams to our past president, Dr. M.K.C. Nair, Dr. Sukumaran, T.U. Sukumaran, who is there in the AOP Gujarat chairing a session with the CAD module where they are paying a tribute to my president, Dr. Major Nagaraju. I got his blessings before coming and joining over here. And today, our guest of honor, our leader, past president, being a guiding force behind all of us, Dr. Sachidananda Kamanji, and our guest of honor for today's event. And also, I thank the organizing chair for this wonderful event, Dr. Madhusudanan, and the organizing secretary, Dr. Yashwant. So with this, at this juncture, I must thank my counterpart, my friend, Dr. T.P. Jayaraman, the president, who has been giving a very nice, beautiful way forward, and the timeline, what all he had done, being coordinated with the government, how government is now wanting to have a advocacy and policy decision that how they tie up with IAP is very, I think, a welcome trend to all of us. So, and also I thank the president-elect, Dr. Vijay Kumar, and the secretary, Johnny Sebastian, and the Wayanad branch president, Dr. Vijayan, and the Yashwant, and the treasurer, Mimi, who has been comparing so well. And without thanking my co-EB member, my senior, Dr. Jason Unni sir, who has been our guiding force and been a mentor for all of us, and my dear friend, Dr. Riaz, and Vijayan, and Jayaraman, and Jayakumar. So, and I must congratulate the coordinator for this event, scientific coordinator for this event, Dr. Fazal and the Habib, for having brought out a very beautiful, I think, series of deliberations by very eminent faculties, and waiting for the Monsoon melodies, which is sung by starting from Dr. Sijaz Suganan and our epic star, Dr. Hima Bindu. At this juncture, I also acknowledge the presence of the NNF president. He is Dr. Ravi. I also would vow to tell that if a Foxy leader also being probably looped or roped in, would be a complete bonus or an extravaganza on this today's event. So with this, my address, my hearty congratulations on this very national event, that is the Independence Day. I inaugurate the 2 days deliberations are going to be very useful to those who have logged in. If I have not mentioned anybody who is on screen, off screen, my Narayan, my guru, my friend, my counterpart, when I was the president of IAP, he is there. He brought in 2020, so many programs. I also acknowledge the presence of everyone on screen, off the screen, and thank you for the opportunity. I inaugurate the event, going to be a great deliberation for the next 2 days, and it is going to be really a good information that we love to learn from the learned leaders and the teachers. Thank you very much for the opportunity given to inaugurate. Thank you so much. Thank you.
Thank you, sir, for inaugurating the program and for the inaugural address. We are fortunate to have Dr. Sachidananda Kamath, past National President of IAP, as guest of honor for today's program. I invite you, sir, to address the gathering.
Thank you, Nimi. Very good morning to you all, and a happy Independence Day. President of today's function, Dr. T.P. Jayaraman, Chief Guest and my dear friend from Vice President from CIAP, Dr. Somshekhar, chairperson of today's function, that is the today's CME, Dr. Madhusudanan, president of IAP Wayanad brand, Dr. Vijayan and other dignitaries on the platform, national EB members, and the other dignitaries, past presidents, my dear friends. It's great pleasure that I have been here in this platform. In fact, as my previous speakers have mentioned that the president has mentioned already that we are really on the last half of the first last quarter of our program for the for this academic year, that is IAP year. I should first of all congratulate Dr. T.P. Jayaraman, who has led our last 7-8 months to a level of wherever we can reach. That is the recognition by the public, recognition by the society, recognition by the government, whatnot. That is what IAP is for. And really, I'm really proud to say that we, the members of all the members of Kerala IAP, I should be proud to say that we have been recognized by all the society as well as the government, in which government has reinvented that we are the best partners of the associations which has been functioning, associating with the government. With the success story of IMR, they are now moving from IMR to the beyond IMR because of the level what we were expected with the single-digit IMR. Now we have to go beyond IMR. That means what we can do for the other children without mortality. We should look into the morbidity also. And definitely, yes, where we are lacking on the nutrition part, and we are still having, even though we are having our health indices in a very high rate, that is the infant mortality low, everything as far as mortality is concerned, we are really doing extremely well compared with any of the developed countries. But we are having a deficiency in the nutrition, anemia, stunted growth, low birth weight, diabetes increasing, hypertension increasing. So adolescent issues are in. So we have to look into the different line of thinking, in which we have been called for a meeting with the government of Kerala. So we all should be proud that we are in a right pathway. I should congratulate each one of you, all the members. This is all the work which all the IAPNs who is doing in Kerala. Each member deserves this appreciation. Without that, we would not have been called with anyone. So first of all, let me take this opportunity to thank each one, which is led by Dr. Jayaraman for the highest post. Regarding this conference, I know that I have been associated with the Wayanad brand since its inception to the level till today, because every conference I make it sure that I attend their conferences. I have been with their summer Pedicons whenever they have conducted, and it was so beautifully they conduct that program. Previous day evening, I still remember those memories that previous day in a hall where we had a night cultural evening and next day CME program on the summer. But somehow we could not meet that through the physical, but they have made it very clear that we will do it exactly what we can, and they could postpone that to make sure that it may happen. But unfortunately, the COVID has moved again and again. So they are planned to go for a Zoom or the digital platform. First, secondly, I should congratulate each one of them with the handful of pediatricians over there who has led this with the seniors which are there, Dr. Madhusudanan and others, and the youngsters who have been doing the job. That is Dr. Yeshwant, Dr. Vishnu, Dr. Vijayan, all others are joined together to form this and made sure that this will be a wonderful conference and wish best for a very good academic feast in the next 5 to 6 hours. Thank you for giving me an opportunity. Thank you.
Thank you, Sachi sir, for the inspiring words. Now I invite President IAP Wayanad, Dr. Vijayan A, to address the gathering.
Am I audible?
Yes, sir, you're audible.
A very good morning to all the dignitaries and participants to this webinar. Respected President IAP Kerala, Dr. T.P. Jayaraman, Chief Guest of this day, Dr. Somasekhar, Vice President CIAP South Zone, Guest of Honor, President CIAP 2015, Dr. S.S. Kamath Sir, President-elect IAP Kerala, Dr. Vijay Kumar Sir, President NNF Kerala, Dr. T.V. Ravi Sir, Secretary IAP Kerala, Dr. Johnny Sebastian, Organizing Chairperson, Dr. Madhusudan Sir, Organizing Secretary AM Yashwant Kumar, Treasurer IAP Wayanad, Dr. Nimmi Koji, all the respected seniors, faculty, friends and colleagues. Happy Independence Day to all of you. As the mankind is fighting an unseen enemy all over the world for the last 1.5 years, we are all very lucky so that we are attending this webinar. My hearty congratulations to all of you for that and keep it up. Regarding this webinar, we actually planned for a physical meeting, Summer Pedicon, which was scheduled for May 23. We made all the preparations including banquet and shuttle tournament as part of this conference. Then suddenly came the second COVID wave and shattered our dream. And just 15 days back, we switched over to this idea webinar, this Monsoon Pedicon. With these few words, I thank all of you who are attending this meeting and all the best for this webinar. Thank you.
Thank you, Vijayan sir, for the address. Now it's time for felicitations. I invite Dr. Vijay Kumar M, President-elect IAP Kerala, for the felicitations.
Respected State President Jayaraman Sir, Dr. Somasekhar, Vice President CIAP and the Guest of Honor, and Dr. Sachidananda Kamath Sir, Chief Guest of the Day, and Dr. Madhusudan Sir, Organizing Chairperson of Monsoon Pedicon, Johnny Sebastian, State Secretary, IAP Kerala, Dr. Vijayan, President IAP Wayanad, and Dr. Yashwant, Secretary, Organizing Secretary, and Dr. Ravi, NNF State President, and all the seniors and my dear friends. Wish you a happy Independence Day to all. It gave me immense pleasure to be a part of Summer Pedicon, hosted by IAP Wayanad. And if I speak to Wayanad, the memory goes back to 1997, 25 years back, when I began my professional career in Batheri after my MD. It was the one time I really enjoyed, both professionally and in my personal life. As whenever I have a problem, the seniors like Madhusudan Sir, Surendran Sir, and Narayanan Sir were always there to help me. And actually, I really enjoyed that 1 year. And this is a real homecoming for me. I wish the program all success. Jai IAP, Jai Hind.
Thank you, Vijay Kumar sir, for the kind words. Now I invite Dr. Jason Rooney sir, National EB member, for the felicitations.
Thank you, Dr. Nimmi, President IAP Kerala, Dr. T.P. Jayaraman, Secretary Johnny, Organizing Chairperson Madhusudan, and Organizing Secretary Yashwant, and all the dignitaries on and off the dais. And of course, Somasekhar and Sachi for being with us today. It's a great thing that the CMEs are continuing. You know, this COVID times, we've been on webinars, and CMEs are a way of keeping in touch with what's happening, latest updates on anything that you need to know about pediatrics. So it's a great thing that at short notice you are doing this Monsoon Pedicon. Wayanad is, my association with Wayanad is because of Betty, Sister Betty. She used to be my secretary when I was president of IAP Kerala. And we used to meet off so often. Of course, at that time, it was Dr. Narayanan, Dr. Surendran, and Dr. Monsoon who were with her. But she was the leading light at that time, And, it's unfortunate that she's not here with you, but it was a great association that I had with Wayanad because of her. I wish this conference all success. I'm sure this is going to be a great event. There's good topics to listen to. I hope everyone's clued on. And I wish Wayanad branch all the very best. All they do, all the best. Thank you.
Thank you, sir. Sir, we also miss Betty ma'am. Now, I invite Dr. T.V. Ravi, President NNF Kerala, for the felicitations.
Good morning and greetings from NNF Kerala. Though I was longing to be present at Wayanad for a real physical IAP conference, the COVID-19 stand in our way, unfortunately. But on this auspicious occasion of the 75th Independence Day of India, I wish to salute the great freedom fighters who gave up their lives for our independence, which we are enjoying now. Those freedom fighters are none other than Mahatma Gandhi, Rani Lakshmi Bai, Bhagat Singh, Mangal Pandey, Chandrasekhar Azad, Subhash Chandra Bose, and many more, whom we remember throughout the existence of India. NNF Kerala always work hand in glove with IAP. Hence, I am delighted to participate in the Monsoon Pedicon hosted by the able Wayanad branch with eminent faculty. I wish to congratulate the organizers of this great conference comprising of Madhusudan sir, Dr. Yashwant Kumar, of course, our great TPJ, Johnny Sebastian, Dr. Vijayan A, Dr. Nimmi, Vishnu Mohan, Suraj, Fasal Mohammed, Habib A, and many others who have made this a reality. I wish the conference all success, and I am sure at the end of the conference, we will be much wiser to deal with many of the pediatric problems in our society now. Thank you very much. Thank you for having me here.
Thank you, Ravi, sir. Now, I invite our dynamic secretary of IAP Kerala, Dr. Johnny Sebastian, for the felicitation.
Thank you, Dr. Nimi. Good morning, all. Am I audible?
Yes, you're audible.
Thank you. Respected Chair, President IAP Kerala, and my leader, Dr. T.P. Jayaraman, sir. Chief Guest of the Day, Dr. Somashekar, sir. Guest of Honor for the Day, Kamath, sir, past National President, a guiding force and mentor of our state branch. National EB members, Jason, sir, Dr. Riaz, Dr. Vijay Kumar, sir, President-elect, Dr. Ravi, sir, our NNF President, past state presidents of IAP Kerala, esteemed speakers of the day, and IAP Wayanad leaders, Dr. Vijayan, sir, Dr. Madhu, sir, Dr. Yashwant, Dr. Nimmi, Dr. Vishnu, Dr. Suraj, Dr. Fasal, Dr. Habib, other dignitaries on this platform, seniors, and my dear colleagues. At the outset, let me congratulate IAP Wayanad for organizing this prestigious sessional conference of IAP Kerala, Summer Pedicon, renamed as Monsoon Pedicon this year due to the current pandemic situation. Hoping to conduct at least this one as a physical one, to meet each other personally and have a nice get-together at Wayanad, along with the academics. Unfortunately, we could conduct only on a virtual platform. But today we have a galaxy of excellent speakers and also some very good topics selected meticulously by the organizers. I once again congratulate the organizers for the same. I wish this webinar all success and all the participants a great learning experience. Thank you. Jai Hind, Jai IAP.
Thank you, Dr. Johnny Sebastian. We have come to the fag end of the inaugural address. I invite our vibrant organizing secretary of Monsoon Pedicon, Dr. Yashwant Kumar, to propose the vote of thanks.
Am I audible, madam?
Yes, you're audible.
Thank you, Nimi ma'am. Respected dignitaries, esteemed faculty, renowned chairpersons, senior members, and my dear friends present in today's platform. I would like to express the mixed emotions we faced while organizing this year's Monsoon Pedicon. The sad part was that we couldn't conduct a physical conference. There is a lot of efforts put up by the organizing committee from the day we offered to host Summer Pedicon till a fortnight ago when it was called off due to the unrelenting COVID-19 cases. The happy part is that we could arrange a virtual conference with an array of excellent speakers waiting to serve you all an academic feast. Back to my duty of proposing vote of thanks. Foremost, I would like to express my heartfelt thanks to our chief guest of the day, Dr. Somashekar sir, Vice President Central IAP South Zone, for formally inaugurating the program and also sharing his thoughts on the occasion. I humbly thank today's guest of honor, Dr. Sachidanand Kamath sir, past National President, for being with us today and encouraging us as he always does. I thank our beloved President of IAP Kerala, Dr. TP Jayaraman sir, for the presidential address as well as his wholehearted support for the program. I extend my sincere thanks to President-elect Vijay Kumar sir, National EB member Dr. Jason Unni sir, NNF Kerala President Dr. TB Ravi sir, and Dynamic Secretary of IAP Kerala Dr. Johnny Sebastian sir for the felicitations as well as their love and support for the program. I thank all the faculty, chairperson from the bottom of my heart for readily accepting our invitation and to be part of this wonderful scientific program. I thank our organizing chairperson, Dr. Madhusudanan sir, for welcoming the gathering as well as guiding us in the right direction. I take this opportunity to thank Dr. Vishnu Mohan, scientific convener of Monsoon Pedicon, who single-handedly arranged all the faculty and chairpersons at limited time. Thank you, sir, for being there with us always. I thank all the members of IAP Wayanad for their constant support from day one of planning of our conference till today. We are not just members in IAP Wayanad, we are a family. Thank you all for giving such a great feeling. I also thank the presidents, secretaries, and members of various branches of IAP Kerala who have obliged our request and are attending in good numbers for today's conference. I thank IAP Wayanad branch president, Dr. Vijayan sir, for his address and also for leading from the front in organizing this conference. Last but not least, I thank Dr. Nimmi Madam, Treasurer IAP Wayanad, for anchoring the inaugural program in a meticulous manner. Thank you each and everyone once again.
Thank you, Dr. Yashwant. Now, without wasting much of our time, we'll move on to the scientific sessions. I invite Dr. Vishnu Mohan, scientific convener of Monsoon Pedicon, to lead the scientific sessions. Over to Dr. Vishnu.
Thank you, Nimi Madam. A very good morning and a very happy Independence Day to all. So we'll quickly go on to our scientific sessions. So first session for today is on FAQs in immunization by Professor Dr. Shija Sugunan. I welcome Dr. Jose O, Additional Professor of Pediatrics at Government TD Medical College, Alleppey. He is also the National Secretary of Pediatric Asthma and Applied Immunology Chapter, National EB member, Central IAP 2015, 16, 18, and 2020, and also the past Secretary of IAP Kerala and NNF Kerala. Over to you, Joe, sir, for the first session.
Thank you, Dr. Vishnu, and good morning to all. We are happy 75th Independence Day to all. And first of all, I express my hearty congratulations to IAP Kerala for excellent activity under the leadership of Dr. TP Jayaraman and Dr. Johnny Sebastian. And my sincere thanks to IAP Wayanad for organizing converting a summer pedicon to the monsoon pedicon and arranging an excellent scientific activity in today's programs. And come to my first topic, scientific. Usually, the immunization is a proven tool for controlling and even eradicating disease. with the immunization campaign carried out by WHO in 1967 and 1977, we are eradicated polio. Now India, already we are polio-free India. We want to free from other infectious diseases also. Regarding the vaccination, routine vaccination in all over India, still there are a lot of queries still existing in our public and even with the pediatricians. Now the field of we are facing a lot of issues in routine vaccination because of pandemic of COVID. And regarding the routine vaccination schedule, a lot of pediatricians are facing a lot of issues. What are the queries are to be clarified regarding the COVID positive patients and even the COVID quarantine patient, how to initiate the routine vaccination role. Regarding the COVID vaccinations, also a lot of queries are coming because which vaccine should be selected, and whether Covishield, Covaxin, or Sputnik vaccine, a lot of vaccines are available. So a lot of queries or doubts are in the public and even the pediatrician and general practitioners regarding this. To deal with this topic and eminent faculties, Dr. Chija Sugunens. Usually the organizing team or any conference, the organizing team selected two important part of scientific content. One is the first topic and last topics, because the first topic should be in such a way that to participants should join in time, so we can start the program in correct times. So I think the Wynad people selected the ideal person to start our today program, Dr. Chija Sugunan. He's an associate professor, SAT Medical College Trivandrum, and is an intensivist and in charge of PSU and SAT hospitals. To introduce Shija Suganan, there is no ways to introduce Shija Suganan to the audience in the India or in the Kerala IAP levels, because she is well known a speaker in especially in the ICU management. For the last 1.5 years, she is doing a wonderful job and educating all the pediatricians, all the general practitioners to the various platforms to how to handle a COVID children and how to manage ICU or the MISC and how to tackle a patient with how to give oxygen therapy and all the aspect of ICU management. He conducted multiple studies times, and all the programs are well led by all the pediatricians and even the general practitioners, and even the physicians are very eager to hear from Dr. Shija in the COVID management. And he also very much interested in the vaccination. He is also one of the leading faculty for all the vaccination program in Kerala or national level. So over to Dr. Shija to clarify the queries for the general practitioners and practicing pediatrician about immunization. And over to Dr. Shija. Welcome, Dr. Shija.
Thank you, Joseph, for those kind words. So esteemed central and state IAP dignitaries, senior pediatricians, and dear friends, good morning, everybody, and a happy Independence Day. So first of all, I thank the organizing team of IAP Wynad, led by Madhusudanan Sir, Yashwant Kumar, Dr. Vishnu Mohan, and team for the opportunity. So going straight to my topic, that is FAQs in immunization. So I think I cannot share the screen. Can you enable it?
No, Vishnu, make Madam as a co-host or host. Who is the host now?
I think, Madam, can you try it now?
Can you
yes. I think
just try once.
Yes. I think it can be seen.
Okay. See.
Yes, ma'am.
Okay.
Make to do.
I'll do it. Right.
Okay. Good.
Okay. So coming to the topic, that is frequently asked questions in immunization in children. So first of all, I would say I wouldn't be really covering a lot of vaccines, but I thought I would just stick on to a few common vaccines which we come across in a day-to-day basis and try to explain the scientific rationale for the solution based on basic immunology. So first, starting with COVID-19, a disease that has occupied our prime time for most of the time for the last 1 year and continues to occupy. So the two common things that is asked regarding COVID-19 is regarding routine vaccination and the impact of COVID, and also what about COVID vaccination per se in children. So when it comes to a question on vaccination, the three important things that we need to think about is where there is a need, what is the efficacy, and what is the safety. We don't have any doubt that routine immunization is needed. Coming to efficacy, COVID-19 is not considered as a disease which causes immunosuppression, so the efficacy is also not a problem. It is efficacious even when you give a vaccine after a COVID-19 infection. What about safety? In fact, whether you give a COVID vaccine during the incubation period or to an asymptomatic child, not COVID vaccine, routine vaccination, it has been found to be safe. So there is no increased report of adverse events in relation to routine immunization and COVID-19 infection. So that comes to the question, how do we really go about it? So if you have a contact with a COVID-19 case, we need to wait for 14 days to get a routine immunization. If you are a confirmed case and symptomatic or asymptomatic, wait for 2 weeks after symptom resolution or negative test to give a vaccine. The reason here is not because the patient will be injured or patient will be harmed by giving the vaccine early, but the reason rather is you don't want to act as a source of infection to the community. That is why the 2-week gap is there. But in case of newborn, if the patient is COVID positive or the mother is COVID positive and the baby is asymptomatic, still the baby can receive the hepatitis B vaccine at birth and receive BCG and OPV at discharge. If the patient is symptomatic, but the mother is HBsAg positive or HBsAg status is not known, there is no contraindication for hepatitis B. In that situation also, you can give hepatitis B at birth along with hepatitis B immunoglobulin. And regarding admitted patients, that is irrespective of the age. So any patient who is admitted with a COVID-19 infection or with any other disease, while at the time of discharge that you routinely do, you are expected to immunize according to age appropriate and only then discharge. Because, so why is there a change? You're telling that after 2 weeks of symptom resolution, you take a vaccine. And you're also telling that every baby can be vaccinated at discharge. The reason is just like what we normally do. If you have a disease and you are recuperating at home, we say that you come when you're completely okay. If you have already arrived in the hospital, if you're already admitted in the hospital, then if I deny you a vaccination, it is a missed opportunity to immunize. So you don't ask them to go and come back. As far as possible, immunize them at the time of discharge. There has also been some confusion regarding blood transfusion and COVID vaccination. There was a child, 1-year-old child, who was supposed to be taken up for an elective surgery. Because of anemia, he needed a pre-operative PRC transfusion. So father wanted to donate, but the father had received COVID vaccine 1 week back. Can he donate? The answer is yes, he can donate. In fact, we need to understand that it is only live vaccines which are contraindicated for 2 weeks till you have for blood donation. That means if you have taken a live vaccine, you wait for 2 weeks to donate blood. The reason here is because in case your blood is being administered to an immunodeficient person, there is a theoretical risk that the live vaccine virus may cause an adverse event in the recipient. So that is the only reason why we say that if you have received the live vaccine, you have to wait for 2 weeks. We need to understand that currently available COVID vaccines, none of them are live. Be it the vector vaccines, they are not considered as live vaccine because the vectors die off soon after administration. So as far as this father is concerned, he can donate blood. Now, when you said that the father can donate blood, the mother asked, will the father be harmed? You are taking blood from my husband. Will his antibody levels come down? Will he be subjected to an infection? The answer is no. You are just giving 350 ml of blood. You have 10 times more blood in your body. And whatever plasma or antibody is removed from your body is quickly replenished by the body. The immune cells will replenish the antibodies. So don't hesitate donating blood or plasma because you yourself are not harmed. At the same time, you're getting a golden opportunity to save someone else. Now, moving on to COVID-19 vaccination in children. We all know that right now our pandemic has not yet abated. There is mutations happening and the spread is still continuing. So population immunity is of paramount importance to really do away with the pandemic. For pandemic to stop, we really need a robust population immunity. And for that, children vaccination is very, very important because they can definitely transmit disease. And whatever it is, even though MISC is considered as a rare disease, but as far as hospitals are considered, it is not a rare disease. It was one of the commonest diseases you were encountering during the peak of COVID-19 infections. So that is definitely a risk. But on the other side, you know that severe disease is very rare in children. And that is why many authorities feel that for vaccination in children, it should not be emergency use authorization, but it should be biologic license application. In case of a BLA, the license is given only after you have safety data for 1.5 to 2 years. So some experts feel that since vaccination in children is not an emergency because the disease as such is mild in them, we have to wait for 18 months of safety data before we administer vaccine. The question arose, in fact, because there were few reports of post-vaccination myocarditis and pericarditis in young adults, but the incidence was 1 in 4.5 million. So now for that, to answer that question, we need to understand that COVID-19 infection causes far higher incidence of myocarditis than vaccine per se. So this was a study done in more than 1,500 US competitive collegiate athletes. They found that 2.3% had myocarditis. Some were clinical and some were subclinical. So when compared to 1 in 4.5 million following a vaccination, 2.3% following myocarditis is definitely vaccine, the risk is minuscule. So as of the time being, for the time being, there is nothing to do away, nothing to be scared of vaccinating a child. So as and when the COVID-19 vaccination gets permission to be given in India, we should definitely welcome the vaccination. That is what the scientific details that we have of now. But by the time the vaccines arrive for us, for our children, probably we will have more scientific data to deliberate upon. Now moving on to the second vaccine, a polio vaccine, a tenacious fighter which has been around here for a long time. And now the IAP has recommended, along with the 1.5 booster, now it has added on a booster at 5 years. So do you really need an additional dose now? When polio itself, the last case in India was 2011, 10 years back, we had the last case, and now we have added an extra dose of IPV. We all know that the VDPV is a real threat. Why are we still continuing with pulse polio? Why is OPV still there in national immunization schedule? So these are some genuine questions that commonly arise in our minds. So to understand that, let us see how the spectrum is. In 1980, there used to be more than 4 lakh cases of wild polio virus annually. And because of the polio vaccination drive, by 2016, the cases had come down to 37. So in 2016, only 4 countries were reporting polio cases. That is, 3 countries had wild polio case and 1 country with VDPV. There were only total of 42 cases, 5 cases of VDPV and 37 cases of wild polio virus. This was a time we decided that we don't want that 5 VDPV also. So we removed the type 2 from OPV. Type 2 was the commonest cause of VDPV. So we removed the type 2, thinking that the VDPV type 2 would come down. And we also introduced the IPV because we didn't want those 37 cases of wild polio virus. We wanted them to be 0. So with that aim, we did that. But what really happened 4 years later, that is last year, 2020 data says that from 4 countries, now polio is being reported from 27 countries. From 42 cases, the cases have gone up to 1,233 cases. We had 2 cases of VDPV2 in 2016. We had removed the type 2. And unfortunately, now we have 1,060 cases of VDPV type 2. So in spite of you removing the type 2, you have had a resurgence of type 2 cases. But I would also like you to look at the map and realize where the resurgence has happened. It has not happened in the developed states. It has happened in the countries where the immunization coverage is low. So we need to understand that when an OPV is given, it gets transmitted from one person to another only if the population immunity is low. When you give an OPV, it does not transform itself to a VDPV the next day or the next week, only if the OPV is able to circulate in the community for months, at least 6 months to 1 year, will it mutate enough to regain its transmissibility and virulence? So that is a very important point to understand. If the population immunity, the population gut immunity is high, OPV cannot transmit and mutate, and there will be no VDPVs developing. So why did the VDPV resurgence happen? Because you removed the type 2, whereas the community was still seeded with OPV. And the gut immunity provided by IPV is definitely inferior. With the pandemic coming, our routine immunization went down further. All these made it possible for the OPV to circulate in countries where the routine immunization was low and cause a resurgence of VDPV type 2. But again, a word of caution, what has come back is not only VDPV type 2, there has been 33 cases of VDPV type 1 also. That includes Malaysia's case of VDPV type 1. Remember, in Malaysia, the polio has come back after 27 years. So the most important thing for us to understand is that OPV causes VDPV, but unfortunately, VDPV can be prevented by OPV. Also, unfortunately or fortunately, you can say, IPV has a very good vaccine efficacy, but unfortunately, the intestinal immunity provided by IPV is less. IPV is mandatory because that's the only protection against type 2. But most importantly, we have to up our routine immunization coverage to more than 95% to prevent development of VDPV. And where do we stand? India stands at a very low level of 62% of complete immunization. And there is nothing to be proud for Kerala also. The NFHS 5 data is out in December 2020. And we have slipped from 82% to 78%. States like Goa, Himachal Pradesh, and West Bengal are currently ahead of us. And so we really need to strengthen. So we need to understand that all these percentages are immaterial when it comes to VDPV and polio. So you have to strengthen your routine immunization, go above 95%, and only then we can think of going for a reduction in OPV or going for a complete IPV. So for the time being, strengthen routine immunization, offer IPV to all patients. When there is a pulse polio immunization happening, please don't discourage people from receiving pulse polio. And as long as the government continues OPV in the national schedule, it is important that we give our babies the OPV too. And one good news is that we have a vaccine which will be shortly available, that is novel OPV2. And this is a more stable variant. And we feel that, and this is the assumption, that this vaccine will not revert to neurovirulence and transmissibility. So that is what we hope for in the future. Now moving on to the next scenario, that is, this was a 3-month-old baby who developed the seizure after the second dose of DPT, which was symptomatically managed initially, but unfortunately the child went on to have multiple seizures and had developmental delay also, and further evaluation revealed that the child was having a Dravet syndrome. So now the question is, what do you want to do regarding the next dose? Do you want to continue with DPT, or do you want to change to acellular pertussis, or do you want to avoid DPT altogether? To answer this question, we need to answer these two. That is, number one is, can DPT cause seizures? The second is, can DPT cause or worsen a progressive neurological disease? The first one, we all know that DPT causes fever, and fever can definitely precipitate seizure. And DPT often unmasks an underlying neurological disease. And incidence of seizure is more with whole cell pertussis compared to acellular pertussis, because the fever incidence is also higher with whole cell pertussis. The second question was more important. That is, can DPT cause or worsen a progressive neurological disease? So it's very, very important for us to understand there is no evidence that vaccinations before or after disease onset affects the outcome of the disease. So when we talk about Dravet symptom, when we talk about other progressive neurological disease, say West syndrome, all these cases, the disease progression is not related to whether you have received vaccination or not. Disease progresses in its own course. DPT does not add on to it. So that's important for us to understand. Remember, you can administer DPT in a patient with an unstable neurological disease, provided the diagnosis is confirmed, the treatment regimen is established, the prognosis explained, and the condition stabilized. But the last 4 things is very, very important. That means you will give the next dose of vaccine only after you have established the diagnosis. So only if you have established the diagnosis, can you say the prognosis to the patient. If you have set the prognosis, can you make the patient and yourself understand that here DPT is not the culprit. So what are the contraindications for DPT? There are only 2 contraindications, that is anaphylaxis to a previous dose and encephalopathy within 7 days of a previous dose with no alternative cause. That means you develop an encephalopathy and you do not have any other explanation for encephalopathy, then it is taken as a contraindication. So now this is something that we all are facing, especially in the private sector. The DPT standalone is not available freely. So can you offer Tdap? The name, unfortunately, is so tempting. It's called boostering. So you feel it can be given as a booster. So can you offer Tdap to a 5-year-old child instead of DPT? If you are giving a Tdap, can he receive the 10 years Tdap, or this is enough? Or does it needs to be repeated? So for that, we need to understand that when you're using an acellular pertussis vaccine, even when you're using the complete antigen content, that is your DTAP, the capital P, the efficacy wanes at roughly 10% every year. Whereas when you're using a Tdap, where the antigen content is very low, the efficacy wanes at a very faster rate, that is 45% every year. So efficacy itself is low and it wanes very, very fast. So we have to understand that we cannot deliberately prescribe Tdap for a 5-year child instead of DPT. But in case you have administered the Tdap inadvertently, that is, you did not know, there was a mistake and you just administered it, then there is nothing to panic because it is a booster dose. It is considered as valid. You don't have to repeat it. In case you have given a Tdap for a primary series, that is the 6-10-14-1, the primary series, unimmunized child coming to you at 5 years, instead of DPT, you have given Tdap, it becomes invalid. For booster, if you have given, it is valid, but for primary series, it is invalid, but Tdap is not a replacement for DPT at 5 years. So that I hope that's clear. So regarding Tdap vaccination, what is routinely recommended is a single dose at 11 to 12 years. But we also need to know that when you're giving the catch-up doses or when you're giving boosters at 16 years and every 10 years, you can give TD or you can give Tdap, no problem with that. But patients above 75 years of age, adults above 75 years of age, instead of TD, in fact, Tdap is preferred. Less than 65 years, TD and Tdap is equal because Tdap, as we already saw, the duration of protection provided by Tdap is less. That is the reason why you are not recommending repeat vaccination. But more than 65 years of age, the chance of mortality and severity of disease with pertussis is high. That is why it is specifically recommended for those above 65 years. And also the mortality is high in infants, especially less than 6 months of age. For them, it is important that they get the antibodies from the mother, and that is the reason pregnant ladies need to be vaccinated with Tdap 1 dose between 27 to 36 weeks, earlier the better. So every pregnancy, you are now recommending Tdap. Now moving on to the next disease, rabies. So this is a topic that I think I get the maximum FAQs for, because how a pet or how an animal reacts to a child and how a child reacts to animal, both are completely unpredictable, and they come to you with different permutations and combinations. So just giving you 3 episodes that we encountered in the last 1 month. The first is a child had a cat scratch 1 month back. At that time, the parents did not do anything, but unfortunately the cat died and the vet said that it was rabies. The second was the child was on a post-exposure prophylaxis child was on post-exposure prophylaxis, not on. In fact, the child had received the post-exposure prophylaxis 2 months back, and now the child has a class 3 bite. So do you want to repeat the vaccination because it's a class 3 bite? The third was the child was on a post-exposure prophylaxis. So while the child was receiving the vaccine, that in between the course, the child had a class 3 bite on the finger on day 10. So he's having a re-exposure. Now what do you want to do? So basically, the 3 scenarios means that the first one is a previously unvaccinated child who is coming to you late after exposure. The second one is a previously vaccinated child who has come after a re-exposure at 2 months. And the third one is a patient who's currently on a post-exposure prophylaxis, but unfortunately now has an exposure with a class 3 bite, which normally you recommend rabies immunoglobulin. So if you have a previously unvaccinated child who's coming late to you, we need to understand that the incubation period of rabies varies from 1 week to 1 year. So the classical incubation period is 2 to 3 months. That means if the child has had a cat scratch 1 month back, child can still present to you with a florid rabies. So it is important that we provide vaccination to the child. And what do you want to do? Do you want to give rabies immunoglobulin or not? That will depend upon the class of wound the baby had. If the baby had a class 3 exposure earlier, if she requires both immunoglobulin and vaccine. If the baby had a class 2 bite, she requires only the vaccine. So the time interval between the exposure and the vaccination does not decide whether you want to give the vaccine or immunoglobulin. It is the class of wound that decides what schedule you want to continue. Now, the second case, that is the patient is 1 week into vaccination. The patient has not received a rabies immunoglobulin. So, and this exposure is a class 3 exposure at the fingertip. So do you want to give rabies immunoglobulin now? So for that, we need to understand why is rabies immunoglobulin given. We need to know that when a vaccine is administered, usually the antigen presenting cell takes hold of the antigen, takes to the regional lymph nodes. In the regional lymph node, the B cells are stimulated. Initially, IgM antibodies are formed, and if it stimulates the T cell, it helps the B cell to migrate to the germinal center, cause a germinal center reaction, and produce a large number of IgG antibodies. After some time, the plasma cells die off, whereas the plasma cell that is hiding in the bone marrow niches continue to provide IgG antibodies for a long time. Meanwhile, memory cells are also formed. So why did I elaborate all this? That is because to emphasize that when you are giving a vaccine, the very next day, you do not have an antibody. It takes some time for your body to produce an antibody. So that is it is to cover this window period, you are giving the immunoglobulin. So you are giving the immunoglobulin to cover the time when the vaccine has not yet acted. So if you have given the first dose of vaccine and the patient presents to you 1 week after first dose of vaccine, even if it's a class 3 bite, the baby does not require an immunoglobulin because by this time the antibody would have been produced by your body. We should also understand that when you're giving an immunoglobulin, it acts only for a very short period of time. It is the vaccine that gives you the continued protection. So you're giving the immunoglobulin only for the bridge, for the window period, and not for the sustained protection. So now coming to the third scenario, that is no vaccination, that is when you are having a re-exposure. So you have completed your pre or post exposure. 1 or 2 months later, you are having a re-exposure. So what do you do here? When you're having a re-exposure within 3 months of a completed schedule, you do not require any vaccination. If you're having a re-exposure after 3 months, you need to take 0 and 3. These are the booster doses. That means you are taking 0 and 3, that is the booster doses. And even if the re-exposure is class 3, for a previously vaccinated person, you do not require a rabies immunoglobulin. So why did I say now that you don't require an immunoglobulin for a class 3 bite in case of a re-exposure in a previously vaccinated child? Because when you have already received a vaccine, you have a lot of memory cells in your body. And when memory cells come in contact with an antigen, it immediately converts itself into a plasma cell and start producing antibodies and destroys the antigen. So there is no lag period. So when you're taking a booster, there is no lag period. You don't require the dendritic cells to come, take to the lymph node and then cause all those reactions. Here, the memory cell itself is getting converted to a plasma cell and producing an antibody. So definitely for 0-3, you don't combine it with a rabies immunoglobulin. So what we learned from the rabies vaccination was that immunoglobulin is important for protection during the window period. when vaccine has not yet elicited a protective antibody response. We also understood that the vaccine is necessary for future long-term protection. The protection provided by immunoglobulin is only very short-lived. In case of a booster doses, you don't need immunoglobulin as memory cells are already there and they respond faster. And rabies immunoglobulin can be offered up to 7 days after the first dose of vaccine. That means this is applicable even for patients who has, imagine somebody has a class 3 exposure, they could not afford the rabies immunoglobulin. They have come on day 1 and have taken the vaccine. They come to you on day 5 or day 3, you can still give rabies immunoglobulin. They come to you on day 7, you can still give rabies immunoglobulin. But if they come to you on day 10, you are expected to continue only the vaccination schedule and not the immunoglobulin. I hope that's clear. So what we learned till now is most important is to strengthen the routine immunization, use every opportunity to vaccinate children. Polio is showing an upward trend. All should receive inactivated polio vaccine, but it is not yet completely ready to do away with bivalent OPV. So as long as the government is offering, we need to continue with it. And the novel OPV2 may be the answer for VDPVs too. Tdap is not a replacement for DPT booster at 5 years. And most importantly, whenever you're faced with a dilemma, apply the principles of basic immunology to find a solution. Thank you.
Thank you, Shija, for an excellent narration regarding the routine immunization that scenario in the COVID era, how to give routine vaccination and in relation with the COVID, and it covered very emphasis on routine vaccination regarding DPT, rabies, and OPV and all. So you told me, Madam Dr. Shija, you told me that there is a surgence of EDPV due to type 2. So why we are trying for a novel OPV2 instead of we can try for trivalent OPV?
No, I think that's a policy decision. It would be difficult for me to answer. The reason is basically because the trivalent OPV that we are using, we know that the OPV type 2 is not a stable one. It mutates. So that is the reason why it is acting as a source. So when you are going to use novel OPV2, which is more stable, it will not get converted to the wild or the VDPV. So that is why they want a novel OPV2, because wherever you have resurgence or whenever there is an outbreak of VDPV, what you do is an outbreak response is done by OPV2. So again, you are seeding with OPV. So when you do an outbreak response with novel OPV2, the seeding will be less. That is what is expected.
So another regarding the one question, I will go to one by regarding COVID. A newborn exposed to COVID, asymptomatic, by BCG immediately and other two are at discharge.
No, it is not BCG immediately. It is hepatitis B immediately, because hepatitis B always we want to give it within 24 hours to prevent the transmission from mother to baby. So that is why hepatitis B is important. In fact, an asymptomatic COVID exposed child, if it is not confirmed, can also receive hepatitis B. So hepatitis B is definitely a priority. BCG, you can wait for 15 days. Nothing is going to happen in the first 15 days for the baby.
And another question Dr. Nisha is asking, I think he is related to rabies only. What about the monoclonal antibody?
Whatever I said about the rabies immunoglobulin, it can be interpreted with the monoclonal antibody also. Nowadays, monoclonal antibodies are preferred because we feel that you're not using it is you can have a large amount. That is one thing. The other thing is that it has a fixed amount of antibody concentration. So that is also a good opportunity. So it is whatever we discussed as scenarios, both are applicable equally, whether it is antibody or it is RIG.
So any maximum time after rabies vaccination to consider the whole immunization schedule on re-exposure?
Okay. Yes, earlier we used to have 3-year cutoff, 5-year cutoff, but the present guidelines don't have a cutoff. So the WHO categorically says that even after 10 to 20 years, whenever you're giving a booster, immediately the antibody response is happening. So definitely, so there is no scientific cutoff that after so many years you have to completely vaccinate. For a practical purpose, if your child is immunosuppressed or for any reason you're too old, you may go for a complete vaccination. But in a pediatric scenario, you don't have to go for a complete scenario in a healthy child.
So another related to COVID, when to take a second vaccine if the patient gets IDRV after taking the first dose of a vaccine? So,
when to take second vaccine if patient gets IDRV
after the
so naturally the rabies vaccination is the priority. So what we normally would do is complete the rabies schedule and then go for the next dose of vaccine. In fact, no interactions have been, like we always telling that 2 weeks gap should be there between a vaccine and a COVID vaccine. We should understand that it is not because an interaction has been proven why this gap is there. The COVID was a new vaccine. You were introducing into a community where before you have long-term safety data. So you specifically wanted to know what are the side effects that patients are coming across. So you didn't want to have it combined with other vaccines where it would be difficult to interpret. So that is the main reason why we ask for a 2 weeks gap. Otherwise, it is not mandatory. So IDRV can be taken. IDRV is the priority. After the IDRV is complete, we can go for the next dose of vaccine.
Okay, thank you, Dr. Sija, for excellent narration or FAQ in vaccination. I think we are running short of time. Lot of questions are there. We cannot will answer in chat box any questions come. So I think we will wind up. Thank you, Dr. Sija, for excellent presentation, and thank you, Dr. IAP Wayanad, especially Dr. Monsoon sir, Vishnu, and all the Vijayan sir and all the team give the opportunity to chair the section. And thank to IAP Kerala for this opportunity. Thank you all. Thank you all. Over to Vishnu.
Thank you, sir. Thank you, Shija madam, for that wonderful talk. And thank you, Joseph, for chairing the session. Next, we are going to our third session. The second planned session, the speaker has some difficulty in joining. So we'll be going to our third session. Session is on diabetes in children, day-to-day care. We have two of our own pioneers in pediatric endocrinology, Dr. Riaz I and Dr. Vijay Kumar sir for the session. I invite Vijay Kumar sir to chair the session. Sir needs no introduction. Sir is a professor of pediatrics at Government Medical College Manjeri and is heading the department there. Also the editor of Pediatric for past so many years and the president-elect of IAP Kerala 2022. Welcome you, sir, to chair this.
Thank you, Dr. Vishnu. My pleasant duty is to introduce Dr. Riaz, but Dr. Riaz doesn't require any introduction to this gathering. And he is a well-known figure, not only in Kerala, but throughout India in pediatric endocrinology circle. And he is currently Associate Professor, Department of Pediatrics, Government Medical College, Trivandrum. And he is President nominee of IAP Kerala and past Secretary IAP Kerala.
Vishnu, I think Vijaykumar is out of the
Sir
has lost the connection. I think.
Connection. I think he lost connection.
We'll go on to the.
Shall I share the presentation?
I think you can proceed. Yes.
Thank you.
Thank you, sir.
Is the presentation visible?
Yes, sir.
Yes. Okay. First of all, I give my sincere gratitude to Vijay Kumar sir for the nice words, and also to the team Wayanad, headed by Madhusudanan sir, Dr. Yashwant, Vishnu, Dr. Nimi. Actually, we all wanted to come to Wayanad in between the pandemic, so we were waiting for that, and I think we will have it as soon as possible. One physical conference at Wayanad. Okay. So coming to today's topic, we all know that bronchial asthma is the most common chronic disease in children, and we all are very much aware of it, and we do learn every time when there is a revision in GINA and all. But the poor cousin, the second most common chronic disease in children, which is type 1 diabetes, I think we have to pay a little more attention, because most of our children with diabetes, after the first admission and stabilization, when they come with a decay and all, we all do very well. But after that, most of them just migrate to adult physicians or adult endocrinologists for their management, only because we don't provide them a place, or we don't provide them some time for managing, for listening to them. So that is why we all need to learn about type 1 diabetes. And regarding the long-term management of type 1 diabetes, if we go back in history, almost 100 years back, it was something like a death sentence. So Sir Elliot Jocelyn had this account in 1917, and he told that most of the children who had diabetes died within a period of 1.5 years, because there was no treatment at all at that time. And with the advent of insulin, actually we can see this is one of those fortunate kids who got that wonder drug, insulin, and you can see how the child has transformed, like we are treating marasmus. So insulin is life for these children who were starving in the midst of plenty. That is, always the blood sugar is very high, but no sugar is reaching the cell, and no energy is being produced. And now the long-term treatment or the long-term prognosis of diabetes is totally different. These two, I don't know how many of you know them. One is Jas Sethi, who is the daughter of our well-known billiards player, and the other one is Indu Thambi, who is a film actor. He's from Kerala. She's from Kerala only. Recently, one film where she is acting as a type 1 diabetic, which is called 18 Hours, is released, and is available in Manorama Max. I wish all of us should see that, because we need to know how they bloom, those children who has type 1 diabetes bloom in their life. But all this improvement in management doesn't come without a price, and that is true for anything in our life. So a lot of things to look at, but once you do everything perfect, then they can have a fruitful, long-lasting life. And the 4 pillars of management always stays the same. It is insulin, nutritional management, self-monitoring of blood glucose in whichever way, be it the glucometer or be it the continuous blood glucose monitoring, and regular exercise without any fail. And most important, how well you are educated, how well the physician is educated, and how well the parents and the child are educated. From the insulin, when you look at the history, everything started from crude extracts from animal. And at that time, there were a lot of glycemic variability, and those children just survived. They didn't grow well, and chronic hyperglycemia was there, and all of them succumbed to complications of diabetes in their early years in life. And then came the human insulins in 1950. Now we have a lot of analogs. Analog insulin, basically the short-acting analogs, which are Lispro, Aspart, and Blulicin, and also the long-acting analogs, Glargine, Detimer, and Degludec. So we should all know about the action profile of insulins, because at least sometime we see that the parents or the child themselves doesn't know that insulin should be given ahead of food. So I have seen instances where food is given and then they go for insulin. So this action, we need not mug up everything, but we should know that the most commonly used insulin, like our regular insulin, the onset of action happens half hour after the injection. So the food should be given after half an hour. And we should know that there is a peak action which can occur at 2 to 3 hours. That is why we may have to supplement that action by giving a small snack in between. That is why there is a concept of 3 major meals, that is breakfast, dinner, breakfast, lunch, and dinner, and 3 minor meals or snacks in between. That is, we should give a mid-morning snack, a mid-evening snack, as well as a nighttime snack. And regarding the short-acting analogs, we should always remember that is the rapid-acting analogs. It is written aspart, glulisin, and lispro. They are very much suited for young children, that is toddlers and infants, because we cannot predict when they will eat. If you are giving a regular insulin and they just refuse to eat, the child can go for hypoglycemia. Here, this short-acting analog can help you. So if it is a very fussy child and you are not really sure that the child is going to eat or not after the insulin shot, we can even ask the mother to just give the insulin along with the food or even after the food, because we now have another insulin which is called Fias for a fast-acting aspart, where we can even give it after taking the food. And this long-acting analogs again is a blessing, because NPH is one insulin which act in a different way at different times. That is, even in the same child, the same dose can cause hypoglycemia on some days. So most of us who are treating diabetes in children had stopped using NPH for children as far as possible. Actually, in some resource limited settings, we may have to, but it is always better to use the long-acting analog, which is available, which is either Glargine, Detamar, or Deglutec in these children, which can actually prevent hypoglycemia. And how many injections is always a question which comes to us once we diagnose a type 1 diabetes case. So always tell them more the merrier, because there are a lot of studies which says that more number of injections can reduce the incidence of long-term complications. Why do we treat diabetes? Why are we after these numbers? It is because we want to postpone the complications of diabetes, the microvascular complications of diabetes in children and to a later age in adulthood. And for that, we need a stricter control, and for that, we need multiple numbers of injection rather than 2 times a day. So it is because we are trying to mimic the normal physiology, where whenever you are taking a dose of carbohydrate, some amount of insulin is secreted by the pancreas. So, but when we are using the split, either the split mix or fixed mix, by telling fixed mix, I am telling about those preparations which are called 50-50, 30-70, 20-80. All those are totally unsuitable for children with diabetes, because it is actually a very rigid treatment, and rigid treatment always causes brittle control of diabetes. The child will be having in between hyperglycemia and in between hypoglycemia. We should be able to adjust the doses along with the sugar of the child. So which is not at all possible in case of fixed mix. In split mix, what happens is there are only 2 doses. 2 doses means there is a dose which is given in the morning. It's a combination of a short-acting insulin with a long-acting insulin. Mostly it will be regular and NPH. And this NPH is going to cover the 12 hours, first 12 hours in the day. And in the evening also another short-acting, usually regular insulin and NPH, where it will cover the nighttime requirements as well as the dinner. So here what happens is, there could be some amount of hyperglycemia which can occur during the lunchtime, as well as there could be some amount of hypoglycemia which will occur during the night. So actually this is this also should be stopped. That is, split mix and fixed mix, both are not standard care nowadays. So now our care, for optimal care, we need actually basal bolus regimen. For basal bolus regimen means with each meal, that is with breakfast, with lunch, with dinner, and sometimes even during evening snack, we may have to give 1 dose of insulin. It can be either a short-acting analog or a regular insulin, along with a long-acting insulin in most of the cases, which will be Glargine. And if it is not available, we can either use NPH also. And what happens in the continuous subcutaneous insulin infusion, that is insulin pump, is we are able to give insulin in very small doses. Very small doses means from 1/10 to 1/20th of a unit we can deliver. And this precise dosing is very helpful in patients who are quite sensitive. We have a few patients, Vijayama sir also knows, they can get hypoglycemia if we just decrease 1 unit of the bolus dose, or they can get hyperglycemia if we decrease the dose. So in those children, we can use the insulin pump. And we can give multiple patterns of insulin also. We can give a regular bolus, which will be delivered fast, an extended bolus, which will be delivered in a duration of time which we fix, and even compound bolus, that is some dose which is given fast and the rest of the dose is given slowly, like when we are eating a dinner, a 5-course dinner or something. And the future all of us are waiting for is a pump which we have multiple hormones, where the other, because we know in type 1 diabetes, after some time there can be deficiency of other enzymes, other hormones like glucagon, amylin, or GLP-1, which can also be given through the pump. And we are all expecting for a closed loop platform where everything is automated and the child can just forget about the diabetes. So coming back to your patient, at the bedside, we should tell the parent on day 1 itself that insulin is the only therapy. And we have to tell this to them every time when they come for follow-up. Don't think that they will believe you in the first instance, or even after 1 year or 2 years or even 5 years after the diagnosis of the disease. They always will have a tendency to go to some other treatment and they will end up in trouble. So make sure that you are reiterating that insulin is life for these patients, and tell them we need multiple doses. Start with 6 doses, 7 doses, and then taper down to 3 or 4 doses. And self-blood glucose examination is vital and it can never be avoided. And whenever you see a child, even in the periphery, start insulin and then refer, because 2 days at home before coming to the referral center can just push the child to a state of diabetic ketoacidosis. And make sure the parents start self-help, that is, they start injecting, they start testing on day 1 itself. Don't wait till the day of discharge. Most of the time what happens is child will be at the hospital for 1 week or 10 days. And then we try to teach them on the day of discharge, and they go home without being equipped. That should not happen. And discuss the options of insulin. What are the insulins available? And just tell them very basic facts about insulin, where to keep the insulin. It should never be frozen. It can be kept in the door. And never inject cold insulin. Cold insulin is painful. We can keep the insulin outside for 5 minutes and then take the injection. And whenever you see a precipitate in the vial, you have to discard. When it is opened and kept for more than 4 weeks, we cannot use that. So all those things we have to tell them. And regarding the regimen, I have told you, we have shunned the conventional regimen, that is twice daily injection. All children with type 1 diabetes should get at least 3 injections in a day. That is with each food. Each time they take a major meal, the child should get an injection. And we can actually have a mix of multiple injection. Well, we can actually, it is like a cafeteria approach. Whoever can afford, we can give the more fashionable insulins. And regarding the monitoring purpose, urine sugar monitoring is not in the list now. And how many times you have to monitor, that is again a question. There again, it is more the merrier, because we can adjust the doses if it is possible. There are mothers who meticulously do the blood glucose estimation 5 to 6 times in a day. And there are people who do it every fortnight, at least every fortnight, multiple times in a day, because that can produce a pattern which we can follow. And which glucometer? A glucometer which has memory, because many of these patients can actually just write down the values in a fair, with a fair control and come to you. Because they do it out of frustration. So we need to have a glucometer which has memory, and we have to monitor that while they are coming for the review. And we should teach them how to look for urine ketones, because with this sick days, when they get ketonuria, we can adjust the doses at home itself by a telephonic monitoring and avoid admission with the DKA. So they should do ketone estimation also at home. And always remember what is the cost difference between these insulins. When we are choosing an insulin for a child, it should be a tailor-made prescription. It is not like that always the costly insulin is the best. It is not so. Some child will be comfortable with a regular insulin. He may be having a better control rather than a short-acting analog. So you have to choose for every child, taking into consideration also the affordability part. And at the time of discharge, the mother should be confident in giving injections. We should make sure they have learned to perform self-monitoring of blood glucose. They should have a good understanding of hypoglycemia and should have a written plan for management. And they should have an ID card, and they should know the basics of nutritional management. And most important is tell them that insulin is life for the child. And whenever they come, you have to verify the logbook. Logbook is so vital because in the logbook, they will write the values, they will write the reasons for why they had a hyperglycemia, why they had a hypoglycemia. We can help them in that. And always compare the values with the hemoglobin A1C, because we all know, all of us want to look fairer, because that is the rule. So children can write wrong values and try to fool you, which is actually fooling them itself. And diabetes and diet, when you are telling about diabetes and diet, children, we have to tell the mothers they need variety, and the food should be having good palatability. Don't give diabetic diet prescriptions to mothers. They can have the normal food which is available at home, taking care of the basic principles. And if you are giving them diabetic food, then we are actually taking away the childhood from them. So when you choose carbohydrates, you choose the complex carbohydrates, because that is always better. And as I told you, it is the most important thing is you should give the injection before the meal. See here, you can see every meal is preceded by an insulin injection. That is how we have to treat. And regarding exercise, exercise is the fourth pillar, which is as important as the other three. So half an hour every day. And if the exercise is going to be prolonged, you have to take a pre-exercise or mid-exercise snack. And exercise should be avoided on sick days as well as when there is hyperglycemia or hypoglycemia. And now there is a shift of monitoring, which is coming from hemoglobin A1C to a new concept called a time in range. Time in range means it is like how much time in a day, 20 out of 24 hours, how many hours the child is having a good control. That is all the numbers are in the expected way. That is how they calculate this. So they say if the time in range is more than 70%, the child is going to have a lesser incidence of what you call complications. So that is the new concept which is coming in. That is why we make use of these sort of tracings, which are called a continuous monitoring of blood glucose, which is done by using different devices for either 7 days or 14 days, which is done by using some sensors and recorders or transmitters. And actually, it also helps in fine titration of the insulin doses, because when we are doing the self-blood glucose monitoring only by using a glucometer, we are taking some still photographs. Here, this is like a video recording of what is happening to the sugars. So we will identify such finer points where we can intervene, where we can give an extra dose or where we can give a snack, and so that we can avoid both hypoglycemia as well as hyperglycemia. So that is something new which we are going into. Then regarding what are our targets? Different societies give different goals, but mostly all of them are similar. we should know that now the target had come to a hemoglobin A1C of less than 7 by most of the societies, but we still follow 7.5 because we are worried about hypoglycemia in children. And the pre-meal values again 70 to 130, post-meal 90 to 180, and pre-bed 80 to 140. So for our clinic, we had made some custom-made targets which are more realistic. Hemoglobin A1C of somewhere near 8, and a pre-meal of 80 to 120, post-meal of 140 to 160, and bedtime 120 to 140. And we never accept any value of more than 200. And two important things which we should teach them is one is how to identify the symptoms of hypoglycemia like palpitation, tremor, then there is blurring of vision, the child can get irritable, there can be increased hunger. So all these things are warning signs of hypoglycemia. And whenever there is such a sign, if possible, do a GRPS. If it is not possible also, or if it is less than 70, always treat it with sugar, with simple sugar, not chocolate or something. And it should be given mixed with water, and it should be followed by a small snack. And make sure that your sugars are normal after 20 to 30 minutes of time. And sick day rules are something which you should again teach them, because the only reason why a child should come back with DKA, if they don't stop insulin in between, is when the child gets sick with some other disease. So whenever a child is having any other febrile illness or any infection or whatever illness, we have to ask them to monitor blood sugar more times on that particular day, and also keep a watch on urine for urine ketones, and then adjust the doses according to the table which is shown or which will be taught to them properly. And it should have a written plan for management of sick day. And most essentially, we should have a telephonic helpline in such days. And also always monitor for the comorbidities, which are hypothyroidism, celiac disease, and Addison's disease. So for all children with type 1 diabetes, the most important one is hypothyroidism, where we have studies from different parts of the country and all show significant number of incidents of hypothyroidism. So make sure you screen for hypothyroidism in all children with diabetes. After the control of glycemia in the initial phase, then after 6 months, and thereafter every year. So autoimmune hypothyroidism we can identify and treat early, because hypothyroidism, if not treated, can also affect the growth of the child, as well as it may cause poorer control of diabetes. And regarding long-term complications, they again look for growth retardation. Every child with diabetes should have a properly maintained growth chart. It's very, very important, as well as Tanner chart, because we need to see that their puberty goes on very well. And also look for retinopathy, nephropathy, neuropathy. And we have timetables for looking at all these. Nephropathy, we have to come and start screening after 10 years with a duration of diabetes of 2 to 5 years by just looking at the urinary microalbumin presence. Retinopathy, again, with the same standard you can do. And every year you have to do all these screens for nephropathy, retinopathy, neuropathy. And macrovascular disease is going to come later in life. As pediatricians, we may not see those, but we have to make sure our children are having a better control so that this can be avoided. So since 2013, we are running a clinic at SAT. We have already phased out NPH, insulin vials, and syringes. Every child is getting a basal bolus regimen, and we are reiterating self-monitoring, and we are using analog insulin pen devices, CGM, CSSI, and all those things. And now we have this Mitai project where we have 900 beneficiaries all over Kerala for children less than 18 years of age, and pediatric departments at medical colleges are having these centers, which will be reaching all the districts. All the districts where there is no medical colleges will be having one satellite center, so that children are going to get care in their doorsteps. So these are some camps which we did, and this is during the pandemic. We were supplying medicines to the nearby district. This was happening not only in Trivandrum, in all districts. In Calicut also, they were giving medicines to all nearby districts. So I think the only one point I just want to tell. One importance of doing this comprehensive clinic is actually there were no decay during follow-up, because we know there were children who were coming with repeated decay attacks many times. But this is a study done by Dr. Devika, our postgraduate, and it was found that only around 3% or 4% of children came with severe decay during the follow-up out of around 400 children. So that is something which is good with having a clinic. And this is our last slide, because when we care for children with diabetes, we have to provide them with insulin and strips. In whatever manner we can procure them, we have to do that, and review the glucose log or CGM if it is possible. During every review, maintain a telephone helpline, monitor growth, use a growth chart meticulously, do screening for the complications as well as do screening for the comorbidities, and let them celebrate their life and childhood. Okay. Thank you. Thank you, sir.
Thank you, Dr. Riaz. And we have to congratulate Dr. Riaz. He has made that vast topic to a very concise one, and all the points that is dealt with a case or day-to-day management by any pediatricians are dealt with in a very lucid manner. And he is a pillar of our Mitai program and also newborn screening program. As far as our partnership is concerned, I think we know each other from 2009 onwards. During that Delhi Pediatric Endocrine Conference, we were roommates actually. From then onwards, I think we used to discuss over the phone or over the Zoom almost every day. So thank you for that very lucid talk. And there are few questions. So I'll just see. One question is from Dr. Jose. Early morning hypoglycemia at 3 a.m. Other periods are having high values. Whether Lantus or Lispro adjustment needed.
Yeah.
It's a very common problem.
Okay.
Yes,
okay. So this is actually the advantage of using a Lantus. And most of the time, if we reduce the Lantus, this hypoglycemia can be prevented. And sometimes, I'm telling sometimes, even Lantus can have a peak. NPH is known to have peaks, and NPH is the culprit which usually causes hypoglycemia at night. But even Lantus can have a peak. In such cases, we can even try degludec. And this for 3 a.m. hypoglycemia, reducing Lispro is not going to help, because Lispro, which you are going to give at the time of dinner by around 7:30 or 8 is going to act maximum up to 12 a.m. only, because the action profile is like that. The action stops by around 4 hours.
Next question, that is from Dr. Manoj. What are the evidences we have so far for the benefits of use of CGM in the management of diabetes in children?
Actually, this CGM, I'm not quoting any study, but from personal experience, sometimes what happens is, even if we do a 5-point blood glucose estimation, like before meal, after meal, like that we follow, but there could be a hypoglycemia which is occurring late night. We may be looking for the hypoglycemia at 3 a.m. But this hypoglycemia would have occurred at 1 a.m. or 1:30 or 2, which we again miss. So many cases of hypoglycemia we actually identify only if there is a CGM. Because what happens is, after hypoglycemia, there is a rebound hyperglycemia which will happen, because many of these type 1 diabetes children will have a small reserve of insulin in their pancreas. So this hypoglycemia will trigger some amount of insulin action, then some counter regulatory mechanism, and then you get a hyperglycemia again. So we won't be able to identify this. So for that, actually, we need to have a CGM in between so that we get a real pattern. And also, if there is a CGM, especially with a real-time monitoring, because now there are CGMs with a real-time monitoring, flash readers. By just keeping the reader near the sensor, you can know what is the value of the blood sugar at that particular time. By using that, actually, the child can go for an extra dose in between. If the child needs to take a snack, he can have it by just looking after this. So CGM is actually a boom in helping these children. And also it can even avoid these multiple pricks for doing continuous glucose, the self-blood glucose estimation in many children. If it has been made affordable, I think the sensors will become less costlier in the coming days, and that will become a standard practice. Vijay sir can add, please.
Yes, I think that is a new gadget, but especially if that question of Dr. Jose, suppose that he has done that sugar at 4 a.m. or 5 a.m., he may miss that hypoglycemia. Though in such way, a continuous monitoring is better if facilities are available. I think we are running short of time, and we will move to the next topic. And one or two questions are there. Dr. Riaz can even answer in the chat box. So congratulations to Riaz again for that wonderful talk, and over to the organizing people for the next talk.
Thank you, Riya sir and Vijay Kumar sir, for that wonderful session. We'll quickly go on to the next session. Next session is on Invest on the First 1,000 Days and Ensure the Best Start by Professor Dr. Himabindu Singh. I welcome Dr. Balachandran, our own dear Secretary of IAP Kerala 2019-20 and Secretary of the ECHG Group of Central IAP 2020-21 to chair the session. Over to you, Bala sir.
Thank you. Thank you, Vishnu. First of all, let me thank the Wayanad team led by Monsoon sir, Nimi, Ashwant, giving me an opportunity to chair the session by an important speaker and equally an important topic nowadays. As you all know, first 1,000 days of life refers to a child's life from the moment he or she is conceived till 2 years of age. And during this time, the nutrition as well as the proper stimulus, healthy and safe environment, family environment, and also, of course, genetics play a part. And just as like in allergic rhinitis, the rule of 4 applies here also. That is, the stats say that the 40% of pregnant mothers say their pregnancy was unplanned, and 40% higher potential for perinatal mortality in babies who are born less than 20 years age from mothers, and 40% children are at risk of not fulfilling their full development potential. And 40% children, another 4 is that 4 things all mothers should be aware when they become pregnant is should abort, and the 4 vaccines which are hepatitis B, MMR, influenza, and Tdap. So all these, and there are a lot more to hear from to enlighten us on this. We have an excellent orator, academician, and leader in Himabindu Singh ma'am. And she is a professor of pediatrics at the Institute of Child Health, Osmania Medical College, Hyderabad. And she's also the professor of the UA, that is the Center of Excellence of Adolescent Health. And she has been the president of IAP Twin Cities Branch B in 2013, and president NNF AP State, and the president of Technical Advisory Group for Birth Defects and Newborn Survival for APA, that is Asia Pacific region, and organizing secretary of many conferences. She has been 3 years as the EB member of Central IAP, national convener of the Indian Academy of Pediatrics Women's Wing 2016 to 19. And she has been she is also faculty of many modules like HIV care, PALS, NALS, IVCF, and neonatal and adolescent health. She is from many universities and Diplomat National Board, Indian Academy of Pediatrics. Best Doctor Award by the state government and Vaidya Ratna Award on Doctor's Day. And 55 publications she has already have in national and international journals. She has been conveying this message of the importance of first 1,000 days of life to all mothers across the country nowadays. And she's AP's successor, who is a lone lady president of IAP after a gap of almost 1,000 days. And let us hear from ma'am. Wish you all the best, Bindu Singh ma'am, for the.
Thank you. Thank you so much, Balachandar sir. It's my pleasure and honor to be invited to this Monsoon CME. I hope I'm audible. Yes? Am I audible, sir?
Yes, ma'am.
Yes.
Yeah.
Yes.
My gratitude
Yes,
to all
you are
the
audible.
seniors, Dr. Ramesh Kumar, Dr. MKC
Yes,
sir,
ma'am.
Dr.
Yeah.
Kamath sir, and of course, my gratitude to Dr. Jayaraman, President of IAP Kerala, and Dr. Sebastian, Secretary. I can see my friends, Dr. Jose, Dr. Madhusudanan, Dr. Vishnu, and Dr. Yashwant Kumar. Greetings from Hyderabad. Thank you. So it is a very favorite topic of mine and very passionate to work on this first 1,000 days. So I right away share the screen. Yeah, I hope my screen is visible.
Yes, ma'am.
Yeah. So we have to ensure the best start. We as pediatricians have the duty to do this. So why our children have to be compromised?
Excuse me.
My slides are visible?
No, ma'am.
Slides are visible?
It's only as showing slides.
Slides are not coming. Slides are not coming.
Not coming.
Stop sharing and restart.
Yeah, stop sharing and restart.
Madam, just stop sharing and share the screen once more.
Stop share, ma. Stop share. Stop share. Again, restart. See, it is open, no? Which one? Now is it visible?
Screen is visible, madam.
It's coming only.
Yeah.
Is it visible, sir? Yes? Visible, sir?
Yes, visible, madam, visible.
Yeah, okay. So thank you for inviting me once again.
Yeah.
So the
it's
1,000
visible.
day story is nothing but the journey from conception to 2 years, 270 days of pregnancy, and first year and second year of life. So this is a very, very critical window. And we have to invest because they are, whenever we take care of the nutrition and the stimulation in the first 1,000 days, they are more likely to be better in their future lives. They're 10 times more likely to overcome diseases. They are having more grades, they earn better, and they are more healthy adults and have healthy families. So what makes us human? Definitely for us, we are different from other mammalians. For the elephant, it is all about weight. For giraffe, it is all about weight, the length. The peacock is all about beauty. But for us, the human child, it's all about the brain. The brain, the story of this starts in the womb. The structure is made in the womb, but the wiring is continuing beyond 2 to 3 years after birth. So this is what shapes us as good adults. So we have to help and support when the brain is being built up, because even though 25% of the brain is formed, only 25% is formed before birth. The rest 75% is still in our hands. This is catalyzed by the epigenetic factors, the environmental stimuli. So this is in the hands of the caregiver. We have to really focus on this. You can see this, though the brain constitutes only 2% of our body weight, it actually controls 98% of our body functions. And the nutrition is very, very important for this brain growth. But along with nutrition, the stimulation is also extremely important. There are 100 billion neurons at birth, but 40,000 synapses are happening actively in the early days. So for this synapsing to happen, so that will retain the neurons. So we have to stimulate the babies in all domains. That is what I'm focusing, because we are doing a little bit of nutrition, but not much on stimulation. Every child requires this to maintain or retain the neurons. This is the pathetic story. As already mentioned by Dr. Balchandar sir, 200 million children under 5 are actually failing to reach their potential. 43% at a risk of not fulfilling their full cognitive development. This is as per the Lancet in 2016. So we have the role to play. We, the pediatricians, have to empower the parents so that together we can create a strong, smarter, healthier nation. Over the base of genetics, which is just 20% actually, over this, there are 3 pillars: nutrition, stimulation, and creating a nurturing environment that can actually lead to a happy and healthy child. I will start with preconception. Why not? We have to start very early. The early, the better. Actually, because this is the need. The justification is 40% of women are actually reporting their pregnancies unplanned. And there's a lot of undernutrition among mothers, anemia. So this can increase the risk of mortality to 20%. And deaths around birth are 50% higher among children born to mothers under the age of 20. That means we have to talk to them about the ideal age. We do not want teenage pregnancies anymore. And all the risk factors have to be identified at least 4 months before the conception so that we can intervene the risk factors. The right nutrition is important for the healthy ovum and sperm 3 to 4 months before pregnancy. So taking balanced diet, maintaining ideal BMI, and managing anemia, having a healthy lifestyle, taking micro and micronutrients is extremely essential. You can see on the right side, these are the RDAs. Especially, I would focus on folic acid, 400 micrograms per day, 3 months before they want to conceive. Because, most of the time they come to us, it's quite late. 3 months, 2-3 months after they miss their period, the neural tube defects are already done, that the neural plate is formed. So we have to tell these young adults to discuss about preconception care. Nothing to feel shy about. When we are educated, we are creating children, conceiving children, let it be a very good best start. So folic acid has to be given 3 to 4 months before. Vitamin D, calcium, iron, and iodine are also extremely important. And we have to tell the young adults to take care of the medications. These are the tips for the preconception care, and screen themselves for hypothyroidism, diabetes, PCOS, etc., to consult their physician, and so that they're a little eumetabolic. And all these are the vaccines which are recommended during before conception: MMR, Tdap, influenza, hepatitis B, HPV, and COVID vaccine. So these are the things to remember. We have to tell them always best is to have a planned pregnancy with good spacing. The ideal age is 20 to 35 years. Screen themselves from all problems, genetic, etc. And they have to meet their obstetrician if they have any bad obstetric history, so that they can discuss how to minimize in the forthcoming pregnancy. So all this, the stress has to be managed. Our young adults are actually getting difficulty in conception. There are a lot of problems, external factors causing infertility, low sperm count, radiation exposure, pollution exposure, chemicals, pesticides, even stress. All this have to be told to our young adults. And if they're feeling low and anxious, suicidal thoughts, any stressors, they have to seek help. So these are the 10 commandments for the preconception care: folic acid, managing anemia, vaccination, screening from infections, medical disorders, genetic problems, maintaining healthy lifestyle, avoid alcohol, tobacco, narcotic drugs, and having a good interpersonal relationship, extremely essential. After conception, this is again important for the baby who's being formed inside, in the fetus. They are also having, the senses are being developed. So there's something called prenatal parenting that has to be advocated for all our younger generation. So the pregnancy should be joyful. And we have to tell our parents what is happening in the fetus and in the mother. In the first trimester, it's a time for orgogenesis. And the first sense, are we aware, pediatricians, that the first sense actually is touch, which is developed in the first trimester. So the child is loving that strokes of the amniotic fluid. So all this is stimulation to the brain. And in the second trimester, swallowing and sense of taste and hearing is developed. So the mother can be exposed to soft music, very nurturing family, and the family has to really support in creating a relaxing environment for the mother. Gender cannot be disclosed. This has to be told. Mother alone is not responsible for the gender of the baby. This also should be told to our community. And in the third trimester, there's a rapid development of neurons. So learning memory is being developed. So this is the time we can actually do prenatal parenting. The parents can spend time, the mother has to be nurtured in a very nice environment so that she can stimulate the baby. There's something called flavor bridge. This is reported in pediatrics in 2001. If the mother is exposed to certain taste even in before birth. Actually, the child prefers all this taste after birth. So if you want our children to take all the foods, what is good, so the mother has to expose that in the prenatal period. So this is a study about carrot juice. Mother was exposed and the babies were preferring this later after birth. And of course, in Indian communities, the elderly people who are, if they are available, they take care of the pregnant woman. It is actually nourishing not just the mother, the child's body and the mind. So this is a very good culture. So the mother has to be taken care of. And of course, she has to be told about the nutritional needs during pregnancy. In the first trimester, not much, but second and third trimester, she has to take care of her diet, and this is what the food pyramid and the food plate. Actually, just telling is not enough. Show them practically. This is what they need to take. The green leafy vegetables, fruits and vegetables, proteins, high quality proteins, extremely important. The weight gain is actually as per the BMI of the mother. So this is the adequate weight gain. If she's obese, we just want only 7 to 8 kg weight gain. This is the pictorially we can show to the mothers what is the various sources of the macronutrients, because just telling them, Amma, take iron, take vitamin D, take folic acid, from where they come. This is what we have to translate our knowledge into some practical tips for the parents. Yes, we also recommend that the mother who's pregnant should be physically active. It can be a stress buster. The baby also enjoys it, but there are certain contraindications. We have to tell the mother to be careful if she has placenta previa, CV anemia, multiple gestation, and it should be a safe exercise. Yoga is extremely good. And of course, breathing exercises, calming down, at least half an hour every day, moderate exercise for 5 days in a week is what we recommend. De-stressing is extremely important. Stress has a lot of impact on the genetic material of the baby. I mean, when the baby is being formed. So that is the impact of stress. Please, we should not take it lightly. It's transgenerational. We have seen there are studies saying if the grandmother had stress, the impact is in 2 generations. So stress has to be managed. And for this, of course, the husband and the family members can help. And now after the taking care of the mother and the baby in utero, now the time when the birthing is environment, birthing is coming, the D-Day. So just few tips to the mother helps her to relax, and how she can prepare, plan, packing the baby's bag with soft cotton clothes, which are washed. Mother can pick up, she can, in her bag, she can have some good music, books, and nursing bras, etc., and share her responsibilities at home, visit the hospital, discuss about pain management, and everything, and have a birth companion, select a birth companion. Exercises till the last day is what is we recommend. At least she can walk, that is a very safe thing. And the father's role is extremely important. We are stressing on the role of the father. The birth companion, this is what now is being recommended by the government of India in private and public sector also. So she can select whomever she wants to. It can be husband also, why not? So choosing, because they have a big role to play. They can support you through the labor procedure, relax you, they can give you, massage you and encourage you. And they are there to even start early initiation of breastfeeding and kangaroo mother care and skin to skin contact. We have to ensure zero separation. This has to be practiced. Kerala must be doing well in all this, but there are many other places in our country where all this is not yet done. Why we having the indicators of early initial breastfeeding is just about 43, and it came down in the latest NHF 5 data. So we are not doing enough. We have to really not only talk. We have to really practically help the mothers and initiate in the labor room itself, because most of them are institutional deliveries. So the responsibility over us has increased. So after the baby is stabilized, initiated breastfeeding, we have to, then there are a lot of questions from parents. What should I do? When should I give the bath? Hair, skin care, skin care. So we have to tell about general infant care to our parents, pediatricians, not just vaccine. Whenever they come to us, please talk to them about how to keep the baby warm, to minimize bathing. No bathing the first 24 hours. We can postpone it for 4 to 5 days, and for low birth weight even later. And the soaps should be whenever we use a soap, it should be very mild, pH 5.5 to maintain the acid mantle of the skin. And use a moisturizer just after bath. Avoid baby powders. Introduce the bath slowly. It should be a pleasant experience for the child. And how to take care of the genitals, washing from front to back. And the diapers. Cloth diapers are better. If you're using a commercial diaper, it should be high quality super absorbent diapers. And there should be some nappy free time to avoid rashes. And we have to talk to them about the massage. Massage is a very good way to stimulate the baby. What are the correct techniques? Because moderate pressure is what is required. We do not require the child has to cry and howl. So it should be very, eye contact should be there. And this opportunity for bonding with the child can be done by the caretaker themselves. About sleep practices also, the parents have to be told, because most of them they do not know. And when the child is crying the night, we know it's normal. We need to tell them that the child takes 2 to 3 months or 3 to 4 months for the child to settle. And the child is more hungry in the night. We know about the prolactin reflex. So we have to talk to the parents, otherwise they get very much disturbed. So some safe practices about sleep on the firm bed, and they nothing to put in the mouth, no bottles at all, and they sleep up to 16 to 20 hours per day. That is the sleep requirement, extremely essential for the growth and development. We also have to tell them about how to induce sleep. Like a half an hour before the baby wants to sleep, we have to off the screens and introduce some routine like storytelling and all that for older children, so that they know that, yes, this is my sleep time. And about breastfeeding, we all know the goodness of breast milk, especially the brain nutrients, which I'm going to stress. We colostrum, we all know the importance. We have to see that all this is early initiation happens and the mother is feeding. But the most practical problems are there still, because why the indicators are so low. Actually, the mother requires practical help to show them about position, attachment, the correct skills of breastfeeding, and how to, relax the mother. Mother has a lot of doubts. I have no enough milk in the first 2-3 days. Common question we all face. I think we have to create a calm and relaxing environment for the mother, and we have to make them understand about the hunger cues, how to give responsive feeding, and how to empty the breast completely because of a hind milk, which improves the weight gain. We all know that, but the mother has to be told. No prelactal feeds, no bottle, no formula feeding at any time. We believe that in many cases, we can do successful lactation for all, including twins. Any situation, the mother can feed successfully. So these are the cues. We have to tell them what are the early cues. We should not wait till the late cues. We also have to make them understand these are the practical tips for the mother. See, the size of the stomach of your baby is so small. Why do you worry about too much milk coming on the first few days? Just counsel them about position, attachment, relaxation, and just ensure suckling, that will initiate more milk production. So we have to also tell them of the science of lactation, about these reflexes, how important it is for the mother to give night feeding, how important it is for her to be stress-free, no doubt at all, improve her confidence, to be involved with the baby. That's more important, but all secretions will come only when she's involved. That is very, very important. And these are the various holes we can show them. Pictures can be put in the OPDs, in the office practice, wherever you are practicing. All these are very good ways to have pictures and show them that all this is possible. Position, I would like to just this is the way. Hold the breast. It should be in a U shape so that it is parallel to the baby's mouth. And that is the way the areola feeding can happen. Otherwise, the nipple feeding, we know that milk will not come. It will call nipples, sore nipples. So these are some practical tips which were not there in earlier modules. I just want to highlight that this is a very, very good way to show them for successful latching and positioning. So these are the various conditions where there can be a problem. So we have to see that the mother and baby are always together, and night feeds are continued, and complete emptying is there, no nipples at all, even pacifiers, artificiality that will cause nipple confusion. For mothers, for our working, most of our mothers are nowadays working, we have to tell them to please utilize all the leaves which are given by the government. And I know your workplace can be, your home can be close to the workplace. You can take some breaks and go feed the baby and come back. And the caregiver 10 to 15 days before you are starting to work, please tell them everything about how to use the express breast milk, which can be kept handy. And when you come back, please continue breastfeeding and night feeding and start complementary feeding. And of course, in the workplace, we are just talking, but let's do it. Shared responsibility. That's the theme of this breastfeeding. We have to support the mothers even in the workplace, give them some space for them to even express the breast milk and keep it. And then there should be some flexible work schedules for them. Remember that breastfeeding is not just a choice, it's a right of the baby and the mother, and we all have a responsibility to support her. And about complementary feeding, start after 6 completed months, very, very important, because why at 6 months, this is the answer. This time the tongue thrust disappears, the gag reflex diminishes, and the digestive system mature, teething is started. So they learn to chew and bite. So, and we also understand the breast milk alone is not enough now. So we have to start good complementary feeds. So I'm not going to say what, I want to stress on how to give. You have to involve the baby. The baby should be able to know about hygiene practices and explore the surroundings. The baby should be able to smell, understand the different textures of food, and should be allowed to become little independent. And there should be no force feeding. This is the early learning opportunity. Show the parent, these are the various foods, millets, they are super foods, not just rice alone. There are so many other good foods, fruits, vegetables, eggs, if they are non-vegetarian, good biological protein, all this has to be advocated. This is one slide I want to say, please practice responsive feeding. Please tell the parents, no force feeding that can lead to behavioral problems. The child should be exposed to all types of tastes, textures, and encourage them, appreciate them whenever they are feeding, and minimize the distractions. No TV, no mobile. Eye-to-eye contact is required. Now coming to development, that's about nutrition, and that every child in the first 1,000 days every child should be stimulated in all domains. Gross motor, fine motor, cognition, audition, vision, speech, communication, socio-emotional, touch, vestibular, kinesthetic, and environmental stimuli has to be given. And why we have to do that? Because we have to retain all the neurons, which are trillions of neurons we are born with, but the synapses have to happen, otherwise we are going to lose it for life. And we have to start as early as possible when the child is in the right mood and right time, alert, and both should enjoy. The caregiver and the child should be developmentally appropriate, and the mother is the best person or the caretaker, and home is the best place, and a supportive family will work wonders. So play, very, very important. That's the only business the child will do. It is, every child is unique, so is their play. Don't instruct them, let them play. You have to just be supportive. They are very, very curious, so encourage exploration and support their play. Do not instruct, and provide an environment where they can have opportunities. Even home, home is a very good, lot of play material is there in the home environment. Need not purchase very costly toys, but let them explore. But we have to be take care of safety also. So benefits of play: improves cognition, creative thinking, imagination, emotional expression. Group play promotes social skills, emotional regulation, life skills, and improves the bonding with the caretaker too and other peers. For 0 to 6 months, you can just, the mother, the caretaker, keep on interacting with the baby, cooing, soft, can keep talking, stimulate the sensory pathways, touch, they can hearing, everything has to be stimulated. Massage is a good way to stimulate, and attend to the child's cry. Maybe that's the only way he can say, I need something. Maintain eye contact, tickling, hugging, kissing, expressing emotions, responding to the infant cooing sounds, voices, touch, smell of caretakers, peekaboo, mirror play. All this is what we can recommend to the parents. These are the various materials, play materials we can recommend to the parents. Because again, I said, even home environment can have, you can see on the right side down, your burthen, your vessels can also be a good play material. For between 6 to 12 months, peekaboo, pat a cake, clapping, calling by name, describing activities, what they're doing, encouraging sharing, and hide and seek, these games, size sorting, shape sorting, simple problem sorting, stars, pretending play, father, mother role, and you can start storytelling now. And peer play, very good. We have to all recommend this. These are the various play materials for 6 to 12 months. For 12 to 24 months, throwing the ball, catching the ball, jumping, kicking a ball, finding a hidden toy, group play, imitation games, storytelling. Now you can ask questions to them. They will, please allow them to scribble papers, tear papers, give them small tasks, and they will imitate you. So you can spend time with them. This is how they develop. These are the various games and toys for 1 to 2 years. Blocks and problem solving games. They can also play with crayons, papers, push-pull toys, etc. Some tips for positive parenting. Remember that parents, we need to tell, as pediatricians, they can tell all our parents, remember your children are listening to you, watching you, learning and imitating. There should be no marital discord or family feuds in front of them. Allow the toddler to make safe mistakes. Encourage them to find solutions. Set realistic and age-appropriate expectations for your toddler. Create a very positive learning environment. And please acknowledge, appreciate them, and validate their feelings. And emotions are contagious. Remember, if you are upset, the child is also going to see that. So practice mindfulness. You relax. When you're disturbed, take your time out, but be consistent with your rules. You can do breathing exercises. You have to manage your own emotions, but look for any unmet needs of the toddler. Safety is our concern. children are vulnerable. It's our duty. We have to keep them safe from domestic accidents, domestic poisoning, abuse, mental, physical, sexual, and even abduction. At home, the child has to be away from this, batteries, toilet clean liquids, kerosene, sharp objects, etc. And avoid throwing the babies in the air. Never leave them unattended, especially with a stranger. And always please watch for recent change in behavior and teach them names of the body parts at the earliest. And all the parents have to understand for under 2 years, what is the typical child behavior? What is normal and abnormal? Every child will require attention, craves for attention, hates being ignored. They're active, busy little people. They are very stubborn and impulsive with little sense of danger. They have very fluctuating behavior. This is again very typical normal behavior. For the causes of, there can be some behavioral issues like temper tantrums, breath holding, but there could be some causes. So let's look what could be. Some faulty parental attitudes can be there, inadequate family environment, any physical illness or any neurodevelopment issues can lead to behavioral issues. And some of them are abdominal colic, for which we know how to handle, reassurance, and thumb sucking. Please do not pull this the child thumb out frequently. That can reinforce the behavior. In fact, up to 2 years, don't worry. But if it is persisting beyond 2 years, the parents can be told to meet their physician. But distractions and positive reinforcement can help. Breath holding spells, anemia, please handle that if you can manage anemia, and also reassure the patient, and ignorance and all those things we need to tell them how to handle, because they get very much disturbed. About temper tantrums also, watch for any unmet needs of the child, and the anticipate behavior before they're throwing a tantrum. What is happening? If that can be avoided, that will be of great help. So there are some guidelines about media and screen. Remember, for below 2 years, only print media, books, posters, and pictures, and digital media is totally off. We do not want them to be exposed. For 0 to 6 months, no exposure to screen. Instead, you can use attractive, pleasant posters, use hanging toys on the cribs to stimulate, introduce light music, lullabies, yes. But for 6 to 12 months, in addition to the above, introduce colorful picture books, hardbound books, which the child can try holding, and different music, audio can be, the child can be exposed to the different music. But for 12 to 24 months, this is the time, no screen time except for family video chatting to develop social interaction and speech and language development. And they are co-watching. The parents should sit with them, and this only for less than 1 hour, that too. Baby songs from sung books can be sung. So these are the guidelines for below 2 years. This is the comprehensive. So we have gone from preconception, why we have to start early, and why, because 1,000 days is very, very critical for brain development and physical and mental development, and what we can do as pediatricians to empower the parents, because the children are with the parents. So we have to empower the parents. So please give them tips about how to plan the pregnancy and how to take care of the child in utero, prenatal parenting, how to stimulate the baby in utero. Senses are being developed. The mother has to be taken care of during the birthing environment. Ensure early skin to skin contact, breastfeeding, complementary feeding, responsive care, and then safety, security, media guidelines, and then general infant care, and also about how to play, regarding the importance of play, and how to stimulate all the domains for this child, and some tips for parenting. So this is the gist of the below 2 years taking care of children. Definitely there's a need to invest in the first 1,000 days, because it's a critical window of brain development, and we have the power to empower the parents. Together, we can definitely transform the next generation by ensuring the best start. Thank you for the overwhelming response you got in this epic module, which was run throughout the country. These topics were taken care of by so many pediatricians. 8,000 pediatricians have been empowered, and we look forward to really translating this into action in the community. Thank you so much. Can I take some questions if there are any? Thank you so much. Again, once more, I thank IAP Kerala and Wayanad who have invited me. Thank you.
Thank you, ma'am. An excellent. Himabindu Singh ma'am is from Telangana, where they have a physical fitness group, where we are concerned about our doctors' financial aspects, and just like that, ma'am has invested in how to go out in the first 1,000 days of life. That was very excellent. And I would like to make one comment that 5 E's ma'am has said during the pregnancy. That is, one is exercise, avoid excess weight, that is maintain BMI. Emotional health is very important. Environment of birthing should be ideal and ensure zero separation from the mother and baby. So that is very important. There is only one question in the chat box. Ma'am, can you answer that? If thumb sucking persisting after 2
Can you
years,
just,
how to
I'm not
manage
able to
that?
see. Yeah, just, yeah, thank you. I would like to thank Yashwant Kumar and Vishnu. If thumbs up in persisting after 2 years, how to manage? Yeah, that is by, we can give them distractions and something else the child has to be busy with when he's putting into the thumb. So some positive reinforcement and some useful activities can be taught to the child. And this is by, again, behavioral change by counseling, and we need, the caretakers have to really get involved with this child. So that this is how we do it. Thank you. Thank you once again.
Yeah, thank you, ma'am. Mr. Mokuthi. Yeah, on the behalf of IAP Wayanad and IAP Kerala State, I thank ma'am for your excellent presentation.
Thank you, Vishnu. Thank you, Yashwant. Thank you so much. And all the IAPians of Kerala, thank you so much for this opportunity. I'm really connected. Thank you.
Thank you, Bindu Madam. It was an enlightening talk on the first 1,000 days work and invest. Thank you, Bala sir, for chairing this session in an excellent way. We'll move on to the next session. We have an interesting dialogue on neonatal respiratory distress by two eminent neonatologists. To chair this session, I invite the Dynamic Secretary of NNF Kerala, Dr. Nelby George Matthew. Sir is HOD, Department of Neonatology, TMM Hospital, Tiruvalla. Over to you, sir.
Thank you, Yashwant. Hi, good morning, everyone. Am I audible?
Yes, sir. Please go ahead, sir.
Yes. First, I would like to thank IAP Wayanad and IAP Kerala for organizing such an excellent academic feast. We have two eminent speakers with us, Dr. Manoj VC, Head of the Department of Neonatology, Jubilee Medical Mission Hospital, and National Executive Member, South Zone, NNF, and our past NNF President, a great academician with various publications in both international and national journals. In fact, indeed, Sir doesn't need an introduction at all for this crowd. Sir has taken NNF to a next level. Then we have Dr. Saujanya S, who has more than 1 decade of experience in neonatology. She had completed her DNB neonatology training from prestigious Mehta Institute, Mehta Hospital, and currently working as consultant neonatologist in Fernandez Hospital. Another great academician who had co-authored several chapters in neonatology books. And we have a very interesting topic, in fact, a very practical topic, that is how to manage respiratory distress in peripheral setup. That is a level 2 NICU. A lot of questions arise in our mind whenever we think of managing respiratory distress in a level 2 NICU. That is it like, if you see, like, is it safe to start a CPAP when you don't have a ventilatory backup? How to optimize our oxygen therapy in a level 2 NICU? Then what are things we have to monitor when you are giving care to in a respiratory distress baby in level 2? And what are things we have, what are the danger side when we should shift the baby to a higher center? I'm sure that this dialogue will most probably give a clear answer to most of these questions, because we have two great speakers with us. Best of luck to both of you, sir. Please we'll start with the session.
Thank you so much, NLB, for the kind words. At the outset, let me thank the organizers for having called me to be part of this great academic extravaganza, Monsoon Pedicon. So without wasting any more time, friends, we will now discuss the common problems that we face in the present day practice. The life is full of challenges, and one of the areas where you have maximum challenges in your office practice is in the field of keeping pace with the current recommendations, especially in a novel branch like, not so novel maybe, neonatology. So with this introduction, let us dive on to the topic. It's going to be a dialogue. So I will be the host and I have a great neonatologist with me, Dr. Saujanya. She is, as introduced by Nelby, she is a consultant neonatologist at Fernandez Hospital, and then of course academician to the core. So friends, I would like to ask you at the beginning, this is going to be a discussion, there are no slides and all, it's going to be a discussion totally, and I want your participation, but we need to manage time also. So like, I would like to know, what do you want to discuss? So can I have your opinion? Please take a second to actually answer the poll. What do you want to discuss today? Whether you want to discuss the challenges in the, can you launch the poll, Saujanya?
Yes, sir, I did.
So
We started it.
Is it visible? The poll is visible?
Yes, sir, I have started, launched it.
Yes, sir, it's visible.
Okay, fine. So kindly answer what do you want to discuss today, because we can't discuss everything, time management. So mostly we will be touching about the various, newborn is a heterogeneous group. We have small preemies and the extreme preterm groups. For those of us who are aware, they are a different category, and one shoe doesn't fit all types of neonates. So the preterm, the extreme preterms below 28 weeks, the very preterm babies, below 32 weeks, 32 to 28 weeks, and then the moderate preterms, the 32 33 weeks, and the late preterm category, which do not have a preterm physiology. They are the actually near term baby. They were originally called preterm babies. Now we know they are not preterm babies, 34, 35, 36 weeks babies. So there's a different category. Then even in term we have early term babies, the 37 and 38 weeks, whose brain is not as developed as a term baby with 39 and 40 weeks. So this is a broad category, and it's the same illness we know is affecting each and every group in a different way. So what is the result? What I am not able to say. I don't know.
So the first option, 59% have voted. So term units mainly, followed by the preterm.
Great. So we will now, Saujanya, you are, I mean, like in your practice, now let us hear, some, I will just, let us start with a scenario, and then we will discuss the case, and this is what most of us face in our practice. We face a problem, then we start thinking. So like, suppose a neonate weighing 3.6 kg was born at 39 weeks. So in the category in which I told you, this is it's a term baby. It has completed its full growth, or which was supposed to happen in the fetal period. Born to a primary mother, born out of emergency lower segment cesarean section in view of thick meconium stain liquor and irregular fetal heart rate. So as usual, baby was received, resuscitated, but she was vigorous at birth. So her ABGA score was 8 and 9 at 1 and 5 minutes. But gradually, over the next 1 hour, she develops tachypnea, intercostal retractions from maybe after half an hour to 1 hour of life. This is a common scenario we find. Now, how are we going to assess this situation? Of course, I will just start and then I will ask Saujanya to take off. So here you have a baby who was vigorous at birth and developed respiratory distress. So naturally, the first question, whenever you assess any baby, is going to be, is it a well baby or sick baby? And the sick baby will give it some signs, and the first signs that you would like to know are the vitals, as all of us know. Temperature is the first one, heart rate, respirations, blood pressure. If you cannot measure, then probably capillary filling time, and then the saturations, and then non-vital important parameters like blood sugar, urine output, etc. also may give some clue. But we all know that the commonest problem we find in neonates is respiratory distress. So respiratory distress, quantifying it is the first thing. How severe is the respiratory distress? So Saujanya, can you tell us how are we going to objectively assess a respiratory distress?
So first of all, happy Independence Day to everybody, and thank you IAP Kerala as well as Wayanad branch for giving this wonderful opportunity to be able to be a part of such esteemed list of faculty. So without wasting time, Sir Manoj sir, as you asked, how do we assess the respiratory distress? So we actually have an objective method of assessing the severity of respiratory distress, and for which we have two scoring systems which are currently in practice. So most of them who are practicing pediatricians must be knowing about this, aware of Downey score as well as Silverman-Anderson score. So why do we actually have to have an objective assessment? So first of all, when we have a scoring system, it is kind of a documentation. So we know when the baby presented, what was the severity scale based on the score. And then after your intervention, how is the baby responding? So whether the baby is improving or baby is getting worse. So do we need to do anything else? So the serial monitoring of the progression of the disease or the course also would be much better when we have the scoring systems in place. So now, when we talk about these two scoring systems, so Downey score essentially takes 5 components which are varied in presentation. So it takes account into the oxygen requirement or the cyanosis, the grunt or the noisy respiration, air entry, that is the clinical auscultatory sign, then how are the retractions, and what is the respiratory rate. So it is a comprehensive package of all the signs of respiratory distress. So when we talk about respiratory distress, essentially we should have a fast breathing or tachypnea, which is more than 60 for neonates. Along with that, we should at least have one more sign, like either a baby might be having a noisy breathing like a grunt or a stridor or a wheeze, or sometimes maybe having retractions which can be intercostal, subcostal, or the suprasternal. So Downey's is a comprehensive package, but most often Downey in clinical practice, it is used for the term babies. Whereas the Silverman-Anderson score, it predominantly focuses on the retractions, like how severe is the work of breathing. So when we talk about preterm babies who have a more compliant chest wall, so that is where they look into the upper chest, the lower chest, as well as the xiphoid retraction. So applying Silverman-Anderson score for the preterm babies who are less than 34 weeks, it makes more sense. But whatever system you choose, you should ideally hang it to the bedside when we're talking about a peripheral setup. So we need not have to actually mug it up, hang it around the bedside. Whenever a baby comes, try to tick the components, score it, and then what is the score at the presentation, what we have done for that, and then how the baby is responding after that. So I think this would give us an idea of how to go about.
Suppose now we are going to assess with, so term baby, we are discussing a term baby. So most of us prefer to use the Downey score. So now the scoring is an objective way of telling you what to do next. So before we do that, we would also like to look at what is the cause of this distress. So this thought process is already started, and simultaneously we would be managing also. So can you be very, very brief on picking up signs from the head to toe examination about the etiology of the respiratory distress? Let's be very brief.
Yeah, so I think when we talk about head to toe, it's a very comprehensive illustrative examination. But when we are restricting to the respiratory system or the respiratory distress, so when we start from the nose, so if simple passing NG tube, it gives so much information. So if we are not able to pass, then we have to suspect a choanal atresia. If there is excessive pooling in and around the nose and the mouth, which is not so normal, which looks very weird, we are doing suctioning, but still we have a lot of pooling, we need to suspect a tracheoesophageal fistula. And then if we are examining the baby for the morose, we see an asymmetric morose, we might have to think about a diaphragmatic paralysis, and maternal history, there might be a difficult labor, shoulder dystocia, fracture clavicle. So that gives us the reason for the respiratory distress. And then if we look at the baby, we have some hepatosplenomegaly, tachycardia, the baby is having heart rate is high. So then the reason for the distress might be a congenital heart failure, congestive heart failure or CCF because of any cardiac lesion. And if their baby is dull and lethargic and there's a history of asphyxia, probably the respiratory distress could be a metabolic one, resulting because of the metabolic acidosis, the baby also might have a deep rapid breathing. So these are the few signs which we can actually pick up when we are looking for the head to toe.
Okay, fine. So like we under this thought process, having taken the history and then having examined this is going on, while at the same time you should be thinking about how are you going to manage the baby. And one of the concepts that we always need to remember when you manage any respiratory distress is there are two aspects which we are actually treating. One is the problem in the lung, and the one is the problem that goes beyond the lung. So what the problem in the lung can be other ways, simple words called ventilation problem, the movement of gas in and out. So probably one parameter that is you are going to target, which you want to keep in the normal levels in this is a carbon dioxide level. Whereas the other problem which is beyond lung, which can be in the lung or can be beyond the lung, which will tell you the overall respiration of the baby is your oxygenation. So we need to identify both these two and then separate both. Why I'm telling this is because we have this practice of putting oxy hood for severe respiratory distress, giving oxygen for respiratory distress. So it is totally irrational when you do that. So the line of management, you have to start thinking at this point itself. So oxygenation problem, or which you easily pick up by your by the saturations, you may pick it up by your rising heart rate, you may pick it up, and eventually it will all end up in the same. So if we are not talking blood gas here, but eventually all the parameters will worsen. But when the oxygenation without respiratory distress and oxygenation problem with respiratory distress, your management would be slightly different. We have now in broadly 3 groups of or rather maybe more, at least 3 groups of machines to manage respiratory distress in a peripheral setup. One is a plain oxygen, oxyhood. The other one is your CPAP, which is a gold standard for respiratory distress, most of respiratory distress to start with, and then the newer ones, of which we will discuss only of 3-4 other, we'll just discuss only HFNC. So when to use, how to use, and what to look for. Like always, when you use stuff, suppose you start with oxygen or CPAP, you should know when you are failing. So signs of failure, you should escalate therapy. So choosing the respiratory support is the first thing that should come to your mind simultaneously. It has to be multitasking. So Saujanya, let's talk about this actually. Oxyhood versus CPAP versus HFNC.
So actually, when we are using the scoring system, it becomes easy because roughly when we use any of the scoring for this matter, in this case, a Downey score, if the score is between 0 to 3, that means typically the work of breathing is very less, and probably the baby has some mild tachypnea and might have cyanosis plus or minus, and saturations may be borderline. So that would make an ideal candidate at a peripheral setup to start only a plain oxygen therapy. But we need to make sure that how we want to deliver the oxygen therapy also is very important, because if we use a hood, we need to have very high flows so that there is no rebreathing of carbon dioxide. So we cannot put 1 or 2 liters and then just give oxy hood. So in that case, eventually the FiO2 goes up, and even term babies, oxygen is toxic. We all know it produces a lot of free radicals even for brief periods. Even in term babies, it can cause a lot of issues. So we need to titrate, and if we can have a blender, at least an air oxygen blender, and then probably we can use nasal prongs and deliver a simple oxygen, provided the distress or the work of breathing is not much. Because essentially, if the work of breathing is high, oxygen only gives oxygenation, as you said. It will not act on the alveolar level. It will not increase the FRC. It will not prevent the collapse or whatever is going on with the ventilation. So now, if coming back to the scores, if they are between 4 to 6, then they will make an ideal candidate for your CPAP. So when to use CPAP and when to use HFNC. Like for example, if we have a clinical diagnosis like transient tachypnea of newborn, I think the distress is not much, it is more of a tachypnea, that baby might help with a HFNC. Whereas if it is a meconium aspiration, or if it is an early term RDS or a late preterm RDS, then those babies would need some PEEP, which would not be equivalent to the flows which are given by the HFNC. They would make an ideal candidate for the CPAP. So we also have to remember that if it is a meconium aspiration, don't worry and jump for the invasive ventilation. There is enough evidence to say that even mild to moderate meconium aspiration can be managed on a CPAP with adequate monitoring. We can get the babies out of it. Now, once we have decided the mode of support, how to monitor. So essentially, when we are putting the baby on any support, the main aim of us is to improve the work of breathing, make the baby comfortable, right? So we need to look at the baby for physical examination. Then we have some targets in the oxygen saturation. If we have the facility for the blood glass, then we have some targets there. So when we are looking at the baby should not be in pain. Make sure the baby is comfortable and the retractions are less. That means the baby is comfortable. And second thing, when we see the saturation targets, we essentially maintain at least 90 to 95%. We have to maintain, and accordingly we titrate the FiO2. And if we are looking at the VBG, if we have the facility of blood glass, then at least the oxygenation should be between 50, above 50, at least 50 to 60 or 80, and then 35 to 45 of PaCO2. So to maintain both oxygenation as well as the ventilation. So these would be the bare minimum monitoring. And of course, look at the babies. If the babies specifically on CPAP, look at the nose. The monitoring of the nose area is very important. Septal trauma, injury, and that causes a lot of pain and desaturation. So that has to be looked in. And when we give any flow which is higher, like CPAP or HFNC, the distension of the abdomen is another issue. So we have to put an adequately sized nasogastric tube through the mouth, and you have to keep periodically decompress the stomach so that there is no CPAP belly or abdominal distension, which will again affect our feeding. So that, and also monitor the color of the baby. Uniformly the baby should be pink. The perfusion, uniformly the baby should be warm. There should not be any cold extremities. Trunk is warm. So again, that means the circulation is not good. So, and also monitor the sugars. As sir started with the temperature, airway, breathing, circulation, sugar. I think these are the bare minimum that we need to monitor in any neonate. Now, coming to the next part, failure. Sir was asking about the failure. So, sir, is that right? So, failure.
Yeah. Before we go on to failure, let us just one point I would like to just add on. Probably there is a concept called precision medicine. This concept came into medicine initially in oncology for cancer patients. Now it has spread to all branches. It has come to neonatal medicine also. Basically, what it means is that it is the same. It's a challenge to adapt the evidence-based medicine into practice. When you do that, what is going to happen is that it is not that same one disease does not have same treatment for all patients. So it is a individualized or customized treatment. Why I am saying all this is, when you talk about CPAP versus HFNC, of course, we all know gold standard is CPAP, and CPAP is the one that there is maximum evidence. HFNC, some people still doubt the evidence part, but we all love HFNC, and in a term baby, we all know these babies like HFNC much more than CPAP. So which one to choose is basically having known the physiology principle. It's your decision based on what the baby tolerates. Effectivity, probably, no, this is an area which I don't want to discuss, which is more effective. There are debates in most of the meetings about whether CPAP is more effective or HFNC is more effective. But another, the patient comfort. When it comes to patient comfort, the interface matters. With the conventional interfaces that you used to use in CPAP, it was not very baby friendly, but now it has comparatively good and comparable patient friendly interfaces as compared to HFNC. So decision is individualized, and a larger baby doesn't like CPAP, you may need to go on to HFNC. To be frank, I always prefer CPAP, but then sometimes babies tell me I don't use CPAP, I don't want it, so we go on to HFNC. Now, one word about oxyhood. Now, WHO now says that when you're using oxygen therapy, better to use prongs to avoid the wastage, and the basic principles that were mentioned. Now, having put that, the next part is, and then you can't sit tight. Especially if you're practicing the peripheral setup, you need to evaluate, is the baby improving? What if the baby is not improving? What if the baby is failing? How do we go around? Yes,
so, simple indications for failure is, if you look at the baby, the highest amount of settings that are required to make the baby comfortable. So it again depends on the unit. As we said, some units are comfortable going up to 6 PEEP only on CPAP, or a flows of around 6 or 7 on HFNC, not beyond that. Some are comfortable up to 7 PEEP. So it again depends on your unit, your previous experience with CPAP, and till what PEEP you could tolerate without having air leaks. So in such situation, usually 6 to 7 people, if we are reaching that much, still the retractions are there and you are requiring FiO2 more than 60 or at least up to 60% to get a saturation or SpO2 of at least 90%. That itself shows that the baby is struggling, would need better invasive ventilation, and it's not going to get better with only non-invasive. If you again have a facility of an ABG or a VBG to be done, then we have to look at the pH. If it is getting below 7.25 or the PCO2 is going more than 55, or you are requiring FiO2 more than 60 to maintain at least of 50 of PaO2. I think these things should help you to make a call and try to make a referral to the higher center.
So why did you start the baby on CPAP? Because of tachycardia and distress. You put the baby on CPAP. There is no improvement. You started because FiO2 requirement was quite high, and then there is no improvement. So then you should have a plan B backup in mind. And if you are not a ventilating unit, that is the time to think about transport. Now, if you suppose you're going to transport this baby, now there are neutral transport has undergone a sea change. The concepts are evolved, but let us just look at what are the basic concepts when you transport a baby. Can you be very brief, Saujanya? How to transport a baby? Now, I put the baby on HFNC has failed, so I tried CPAP. Baby is tolerating CPAP, and still baby is having distress. Now, I need to transfer this baby to. I don't have a ventilation in my unit, so I need to transfer. How do I do it?
So I think essentially a successful neonatal transport is where the baby should not destabilize during the transport. So that is our aim, it should be. So in order to prevent the destabilization of the baby during the transport, what we should do, we should have a plan that we already have communicated with our team, and the place where the baby is going to be transported, the communication is very important. So informing them in prior hand that this is what we are going to do, this is the baby, this is the case. So this handing over what we call and the communication, that helps them to prepare whether they are ready to take this baby, or if they are not ready, then what is the alternative. So unplanned transport should never be done. Second thing is, whatever is the primary etiology, try to correct it as much as possible. And during transport, I think the most important things which can go wrong is temperature. Most importantly, the babies get hypothermic. Second thing, they get hypoglycemic because of disconnection of fluid for some time. And if they're already on inotrope support, they might get hypotensive or get into a worse shock. So these three things are the most dreaded things that might happen. And of course, the need for intubation. So you should have a person, a doctor, a pediatrician is enough. You do not need to have a neonatologist all the time, a pediatrician and a trained nurse in neonates. They should accompany the baby to transport. To prevent hypothermia, nowadays we have this heat gel mattresses, that is the Embrace, that I think most of them are aware of, where it is a gel pad, which is a thermostatic gel pad, and then there is a wrap in which you can actually place the baby. So always make sure that you use these Embraces wherever possible. Otherwise, at least wrap the baby properly and try to prevent hypothermia. Infusions have to be there. So the ambulance where we are transporting, or whatever you are using vehicle, it should be customized at least a bit for the neonates. That is very important. And making sure that we always have the emergency drugs like adrenaline, normal saline for resuscitation, intubation for functioning laryngoscope, and ET tubes based on the baby's weight. If they are available in the ambulance, if anything goes wrong during the transport, I think we can immediately revive and resuscitate the baby. And again, I think these are the basic, most important points to prevent any destabilization. Hello.
Great, Saujanya. So that has covered most of the things that need to be looked at. To transport a baby from, say, Sultan Batheri or some place in Wayanad all the way to Calicut is going to be a tall order. One of the things that you need to really look at is who is accompanying. It's a tall order to have a pediatrician. But it means we are the only one in the place to accompany. If that is happening, so the person who goes should be sensible. And we live in the smart age, smart era. So basically, always the communication channel should be open between the ambulance and both the centers. Whichever center, and then there should be it should be a live sort of communication. There are good apps now available which are being developed to do this, so we should try these models as well. Now, one of the points that you need to tell the driver is to go as slow as possible. I keep telling this because the drivers rush at 200, they ride the van like a aircraft, actually 200 kilometers per hour. This is going to create problem. If it's going to be a pre-term you are going to transport, you are going to definitely create some brain injury. So we need to go as steady. Why? Because there is a concept called dynamic and adynamic stress that the baby undergoes, and the dynamic stress is going to be exponential if you're going to go fast, because at that it's okay to go fast, but then you can't brake immediately. And look at our roads, look at the turnings in and the gut. You cannot go fast, go slow. So the steady speed is important. There are other things already covered now. Suppose we are not that unfortunate, our baby has now responded to CPAP. Putting the baby on CPAP alone is not enough. We are not super specialists. I hope there are no super specialists in this group. We are all pediatricians. So basically, we don't want to look at a system. We don't want to be nephrologists to look at the kidney alone, or the cardiologist to look at the heart alone, or pulmonologist to look at respiratory system alone. You are managing the baby. One of the things that you need to initiate as soon as the baby is born was well pointed by the previous speaker, Himadubindu madam, was skin to skin care. And this goes a long way in the first hour, skin to skin care in the golden hour. Why I'm saying this? Because one of the things you are going to start immediately as soon as the baby is stabilized is start feeds. You are not going to wait for the respiratory distress to stop, or rather resolve to start feeds. So feeding has to be, the question that you should be asking is, which minute I am going to start feeds, not even which hour I am going to start with. The first feed has to go into the baby, and preferably mother's own milk has to go into the baby as early as possible. So the guidelines, we will not discuss the details about the feeding guidelines. It should be now we have gone away from the concept of keeping the baby NPO for respiratory distress. Babies need to be on feeds. Now, another area where we tend to actually overdo. This is again, feeding is where we underdo. Another area where we do to overdo is in the usage of antibiotics for respiratory distress. Soumya, your views on this?
Yeah, so first is feeding. Yes, of course, feeding is a very essential part of our
No,
supportive.
let's go on to, because of time. On to the next, antibiotic use. And
Antibiotic use. So I think the moment the baby has respiratory distress, I think it has previously become a practice where people are more scared because of the fear they start the antibiotics. But we need to look into two aspects. One is the baby as such and the clinical presentation, and second thing is the maternal history or risk factors and the day of presentation. So if we are looking at the baby who's immediately born, just like this baby, if we are starting antibiotics, it is for the early onset sepsis or the pneumonias. So in that case, maternal history is very important. So if mother has any significant risk factors for sepsis, like she has a fever about 38 or 39 degrees Celsius, she has obstetrician tells that there was a foul smelling liquor, or there was a history of chorioamnitis in the mother. She had a GBS, high vaginal swabs were positive in the past pregnancy or current pregnancy, and she has a leaking at least of 18 hours for a preterm or more than 24 hours. So these are very significant risk factors which can cause problem in the baby. So in such situations, if the baby is having respiratory distress more than 4 hours, then we have to start a empirical first line, but always make sure that send a blood culture for the baby, because it will help us when to stop. So that will help us for the de-escalation. So always make sure you send a blood culture, and don't use broad spectrum antibiotics. So we at Fernandez, we use a single monotherapy first line with only amic acid. So we do not even give two medications. So it is based on your unit. After discussion and seeing your previous cultures, you can always devise your first line, second line, third line, but always, no matter how sick initially the baby looks, start with the first line. Now, if it is a preterm baby less than 35, even the maternal history is positive, there is mild distress, you have a lower threshold for the starting antibiotics. If the term baby looks well, then comes a role of a septic screen. So you have to remember that if you are doing septic screen, that is the CBC and CRP, then you don't start antibiotics. You have to wait for the report, you look at the report and you take your cutoffs, and if they are positive, then you start. If they are negative, then you wait and watch and continue the supportive management with respiratory support and repeat after 12 to 24 hours in case the baby is worsening or not responding. And if the serial CRP shows an elevation, then you are justified in adding. But always make sure that when you start, send a blood culture. If it is negative, try to stop at 48 hours or even earlier.
Now, some of the challenges you may have in the use of antibiotics, always that gives us a feeling of comfort, like, okay, we are covering at least for one cause. So identifying the cause, as you said, is very important in the initial period. And probably the dictum is the start with the, as we explained, the start with the narrowest spectrum possible and hit hard, which means that you use a correct dose, not homeopathic dose, and then stop the moment you are convinced the baby does not have sepsis. Do not wait for 3 days or 5 days or 7 days, sacrosanct days we have been told. There's nothing like that. You can stop the antibiotics at 36 hours or 48 hours. Whenever you are convinced there is no sepsis, you need to stop. This is very important in the managing the antibiotic profile in your unit. Talking of which, one of the antibiotics which you should not start as first line is cephalosporins. It is going to spoil your unit. So never. There is a good. It's a common practice that people all start with cefotaxime and cefotaxime, gentamicin or something as a first line. Please don't do that. You can start crystalline penicillin and gentamicin, or ampicillin and gentamicin. Probably these are two preferred regimes. Or if you feel that GBS is not a problem, then you can even start with gentamicin alone. But do not start with cephalosporin. So let's now move away from antibiotics. So the less you give, the better. If you are convinced, you give, because that is not going to solve your problem. You need to actually look at the endpoints for resolution of sepsis. Now, what if this baby was a 35 weeks baby or a 34 weeks baby? It is so this is a different group. We are talking about 39 weeks all this while. So how will you approach differently? Can you just tell us, Saujanya, if it's a late preterm baby?
So if it is a late preterm baby, then the threshold to start the respiratory support should be low. Because though they look little bigger than the preterm, so they are the bridge population who are always neglected, but the studies have shown that they are at higher risk for respiratory morbidities like RDS, TPNB, and also a lot of metabolic complications like hypoglycemia, hypocalcemia, magnesemia, hyperbilirubinemia. So that's the reason they are very unique and they are more at risk and vulnerable. So definitely, if this was a 35 weeker or 34 weeker with this much amount of distress, I think straight away the baby would be started on a CPAP or a respiratory support and look into the risk factors for sepsis if needed to be started on antibiotic. Aggressive feeding has to be started, and watch the metabolic parameters also. So prevention of hypothermia, hypoglycemia. So that should be the aggressive approach towards such a small baby.
Great. Now, before we proceed further, Dr. Nelby, how much have we exceeded our time, or how much time do we have so we can plan the further discussion? Or our organizer, somebody can tell us.
Sir,
yeah, Vishnu. Not able to.
Sir, can take five. Sir, three more minutes and wind up, sir.
Okay, so we will not go to preterm then. So 3 more minutes means I saw a question in the chat box. There is no role for oral antibiotics. Actually, people are now started. We are not talking about research. We are not talking about established norms for clinical practice. So you cannot and you should not start oral antibiotics for any neonate. For that matter, it has to be always parenteral, because the absorption is erratic and you are going to destroy your precious guardians, angels in your gut, the microbiota, when you straight away give it. It's not that if you give IV, they are not going to be destroyed. We are going to destroy it without any effect. At least when you give IV, it is going to act. So no role for oral antibiotics. So can I ask Dr. Saujanya just 1 or 2 sentences to sum up, then I'll also give my remark, then we'll hand over to you. Yes. Just let's be brief. I apologize to everyone. We are not able to discuss the second case. Time is a big factor. Sorry for that. Yes, please go ahead.
So I think To keep it simple, whether it is a peripheral center, tertiary center, I think first of all, don't get that into your mind. Always remember that sometimes the bare minimum that we do is going to make a huge impact. So I think the basic like prevention of hypothermia in the delivery room, starting the skin to skin contact early irrespective of gestation, giving breastfeeding, emphasis on breastfeeding, starting CPAP, simple CPAP with adequate monitoring. So these things will help, I think 90% of your babies to get through at your own center and place. And with rational and judicious use of antibiotics, what we call as antibiotic stewardship, I think with these we can achieve excellent results. So don't think that if you don't have ventilator, you're not going to offer much to the community. No, only non-invasive is the way forward. And if properly used, it salvages most of the babies. I think that's what I want to keep it simple. Even if you have a very small baby, like 28-week born, just don't panic. I think there is so much that you can do at your place to give better long-term outcome, like delivery room CPAP, hypothermia prevention, and surfactant, early surfactant. So these are all the things which even at a peripheral setup can be given. With proper planned transport, I think you can make that difference to the community.
Great. Thank you so much. Now, just to add on a few more points, or rather want to stress on some more points, there is something called golden hour. Golden hour is not for preterm babies alone, for all babies. And why are we saying this? Because we now believe in prevention rather than treating. We don't want respiratory distress. Even if the respiratory distress is going to be there, we want it to be mild, not moderate. We don't want the Downey scoring to be so high. We want to keep everything as low as possible. The babies, now we have enough evidence, enough and more evidence to say that you babies who are initially put on mother's abdomen, skin to skin contact in the first 1 hour of life gets more milk, definitely. So that all those advantages, and then prevention of sepsis, breast milk has a great role, and early detection of sepsis, keeping your eyes open on what is wrong. Have that. It's not just the knowledge, that wisdom has to come by seeing babies. And when is the right time? So the earliest you need to, starting a non-invasive respiratory support, you don't need to wait. But mind you, do not use indigenous CPAP as was the practice where there is no blender, no oxygen. So it has to be, if you just want to start, if you have a compressed air, you start with that, which is not, I don't think people will do that. They don't have the compressed air, they will have compressed oxygen. So probably CPAP has to be with a blender, CPAP with a blender. Start with 21 or 30%, whatever is the age group you are looking at, put on CPAP and then monitor, are you getting benefits? Baby is not liking it, change over to HFNC and see whether it's being as effective. If whatever is the unit policy, go up on the pressures and see if it is effective. If baby does not have distress but has severe, desaturated, or rather target saturations are much less, these are candidates for oxyflow. And when you start baby on any mode of support, look for signs of failure. If you are not getting benefits or if it's worsening, it's time to scale up, and you should always have a plan B ready. I think we will stop here because of lack of time. So I would really like to thank first of all Saujanya for being very brief and like answering to the point. I was trying to act as a host. I know that I have not done a proper job for that, but then something I had done. And now let us actually the challenge is to all the, we have heard like so many things, like having an embrace, having a pediatrician to accompany, all these we don't have. But what we have, with that, let us not go wrong. Certain things we can we can commit, certain mistakes we can avoid, like just starting with cefotaxime as a first line, or like starting antibiotic when it was not required, or just starting with 100% oxygen. So let us actually try to improve from that and then try to evolve. Over to you, NLB. Sorry for taking long time.
And sorry, one last thing, hand hygiene. COVID has taught us this, so that will help our units go a long way.
Yes.
Thank you, Dr. Saujanya and Dr. Manoj, for the excellent dialogue and so enthusiastic dialogue. Just to add one or two things, sir. One common mistake, just from the whatever you were discussing, just one common mistake we all tend to do is just to give hood box oxygen for work of breathing. Just when we go to our unit, we see the baby is having saturation 95, 96, just keep name. Why you are giving a hood box oxygen? So rate was around 80. These babies doesn't need oxygen. These babies, what they need is pressure support. as sir was mentioning, they need CPAP. And next thing, as Dr. Saujanya was saying, you should see for complications. This distended abdomen. I feel if you are giving CPAP in prone position, that may help in venting out the air. Another thing is, what the last thing what we doesn't want is when you are giving CPAP is air leak, pneumothorax. You may not be there 24 hours in the NICU. So even if that occurs, we want to pick it up at the earliest. So what we do is train our staff. If the FiO2 requirement goes up by 5%, immediately see for transillumination so that we can pick up. I think that can help in avoid late diagnosis of pneumothorax. I just want to get an opinion from sir and madam.
Actually, you're right, Nelby. That is fine. I mean, the worst thing that you can do is an iatrogenic damage. You don't want complication of your treatment to, especially in this era, not of medico-legal litigation. But even without that also, it's not morally justifiable to do that. So definitely look for complications. And then when you have anything, not even saturation, FiO2 requirement going up, heart rate, baby was on a heart rate of 130, 140. And then after some time, baby's saturation is being maintained because that is what the nurses do, just look, saturation. But the heart rate is now 160. So there is a problem. One of the first thing is, am I doing right? Is my treatment doing right? This question you need to ask, and immediately one of the things in CPAP which you can have these days we don't see because we are optimizing our treatment. But we used to get this actually in a previous era of air leaks. So we do not want air leak. Air leaks is a grave mistake. Feed intolerance is partly a myth and partly yes. Definitely, that is actually depends on the feeding regime. You can tailor made. Sometimes it's not a 3 hourly, sometimes 1.5 hourly. What the baby tolerates without developing CPAP belly. Well said, Nelby. Thank you.
Thank you, sir.
And regarding the air leaks, regarding the air leaks, I think most of the times, as sir said, it's just not the saturation. Look at the color of the babies. Just see initially the baby looks so off-colored. The baby was pink, suddenly it looks dusky and off-colored. As sir said, it can be extreme tachycardia. You always think because of the pain, because of the Brown's baby's tachycardia. No, that is not the case. So sensitizing our nursing staff to alarms and not just muting them, but looking at them, why it is happening. Sometimes they just, if there is a dip in the saturation, they increase FiO2, and once it picks up, they are like, okay, fine. No. So these things, I think, look at the color, perfusion, the heart rate, the work of breathing. If a baby who was comfortable suddenly starts showing any of these abnormalities, always suspect on CPAP. It can be a leak anytime. So that is one thing. Yeah.
Thank you, Dr. Saujanya. I think we are running short of time. We'll move on to the next session to the organizers.
Thank you. Thank you.
Thank you, Manoj sir and Dr. Saujanya, for the thought-provoking discussion on neonatal distress. I know actually you had so much to discuss in neonatology. We'll invite both the speakers once again for our conference, sir. Thank you, Doctor.
I wish it was a physical conference. We could have come to Wayanad, on a holiday.
Yes, sure. I would be looking forward. Thank you.
Thank you, Dr.
everybody.
Nelby George,
Thank you,
for sharing and summing up the sessions in an impressive way. Thank you, sir. We will move on to the next topic, which is on pediatric surgical emergencies. To chair this session, I invite Dr. Nandakumar MK, Senior Consultant and HOD, Department of Pediatrics and Neonatology at Aster MIMS, Kannur. Sir is also our National EB member. Over to you, sir.
A very good afternoon to all. First of all, I thank IAP Wayanad for giving me this opportunity to share this very important session on pediatric surgery emergencies. In our day-to-day practice, we used to encounter a lot of pediatric surgery problems where time is very, very precious. Timely diagnosis and referral to a pediatric surgeon is very, very vital in there. So to talk on this topic, we have a well-known and very experienced senior pediatric surgeon with us, Dr. Abraham Mammon, who is a head of department, senior consultant in Department of Pediatric Surgery at Aster MIMS, Calicut. Sir is also a chief of medical service in Calicut, Aster MIMS. He's completed his MBBS and MS surgery from CMC Vellore and did his MCH in pediatric surgery from IMCH Calicut. Then he undergone advanced training in pediatric and neonatal surgery and especially laparoscopic surgery at Royal Children's Hospital, Melbourne, and started his career at MOSCM Kolanjeri. Then he joined Astromims Calicut in 2001. And apart from his academics, he is having PG diploma in medico-legal systems and hospital and health care management. And he is the co-author of chapter of pediatric and neonatal surgery in Cloherty Stark's Neonatal Manual in Southeast Asia. It is brief introduction. I am handing over mic to sir.
Thank you, Dr. Nandakumar, for those lovely words. I would like to start by saying a big thank you to the Wayanad IAP, Kerala IAP chapter for giving me this opportunity to present my views on pediatric surgery before such an august body. Give me a minute while I just share the slides. Okay, are my slides visible to you?
Yes, sir. Please go ahead, sir.
All right. Thank you very much again. Thank you. I bring you greetings from Astromims Calicut. As everybody said, it's a pity that we could not physically meet together. This would have been an ideal opportunity to get together in Wayanad, but things are better. Things are totally different from what we've expected. So wishing you a happy Independence Day and a lovely conference. I would like to go on to the topic which I've been given, which is actually pediatric surgical emergencies. Now, I would not like to talk about the surgical procedure and surgical techniques, etc., because I don't think that is required for you. But I would like to just stress about what a pediatrician needs to know with regards to pediatric surgical emergencies. That I think would be more practical for you all. Now, all of you all know the various symptoms that a baby can present with a surgical baby can present, whether it's a neonate or an infant or an adult child, like vomiting, abdominal distension, pain, meconium abnormalities, urinary symptoms, breathing problems, feeding problems, excessive salivation, drooling, etc., and even obvious malformation. But what I would like to stress over here at this point is a well-taken history, especially from a well-known carer like a mother or something, gives you a lot more information than many other things. So history taking is very crucial as far as surgical topics are concerned in pediatrics. Just a few words about vomiting, because this is one of the cardinal symptoms of pediatric emergencies, especially newborns. We need to take a few things when we talk about vomiting. Age of onset is extremely important. The significance of it is definitely more when in the neonatal period. As the age goes up, a lot of other non-significant vomitings do occur, but then still you need to keep vomiting as one very important sign of history of pediatric surgical emergencies. The differentiation between bilious and non-bilious is extremely important, and especially in a neonate. We are all taught bilious vomiting in a newborn, the sun should not set without making a diagnosis. So bilious vomiting has got grave prognostic features and therefore should be considered very, very strongly when we take a history. We need to make the difference between vomiting, true vomiting, positing, and drooling, because all of them have got different significances. Association of vomiting with abdominal distension is again significant, as also when it is associated with constipation. Some of the commonest causes of vomiting in a child, bilious vomiting in a newborn, include congenital conditions like diurnal atresia, diurnal stenosis, malrotation and volvulus, which is very, very crucial, and I'll spend a few minutes later on that point. Intestinal atresias of the jejunum and the ileum, necrotizing enterocolitis, Hirschsprung's disease, anorectal malformations, etc. In older children, you still could get certain congenital malformations presenting much later, like bands and malrotation, etc. But more often it is acquired, and intussusception is a very, very common feature resulting in pediatric emergencies in an older childhood. Peritonitis of various causes, either primary or secondary, should be kept in mind also when you're dealing with these children. As mentioned earlier, malrotation is very important because it is a life-threatening and a very, very serious condition if not diagnosed and treated energetically early. The photograph on the left shows the normal orientation of the gut in a child. Stomach on the left side, the first part and the second part of the duodenum traversing the spine to the right side, a well-formed C loop of the duodenum with a DJ flexure on the left side. The serpentine small bowel covers the entire abdominal cavity and ends at the ileocecal junction, which is classically in the right hypochondrium. Then you have the ascending, transverse, descending colon and the rectum. Now, this is the classical rotation result at the end of a proper extracoelomic rotation of the gut. In malrotation, is what you see is on the right side. The cecum, because of the absence of the rotation, the cecum is in the subhepatic position, and the normal retroperitoneal bands which cross between the cecum to the right in the right iliac fossa to the lateral abdominal wall cross from the cecum across the second part of the duodenum to the abdominal wall, and this is what is called Ladd's bands. Secondly, the duodenojejunal flexure and the ileocecal junction are very close by. There is a short mesenteric base, and therefore there is a high chance of resulting in volvulus. The two important these are the classical x-rays of malrotation and intestinal atresia. Malrotation, you get just two air bubbles, the distended stomach and the duodenum. So double bubble appearance of malrotation is classical, with absence of gas shadows further down. On the other hand, when you have an ileal atresia or a jejunal atresia, you find multiple air fluid levels, especially in the erect posture, which results in a suggestion of intestinal obstruction. Barium meal of malrotation shows the stomach on the left side, duodenum crossing to the right side, the C loop of the duodenum not being formed, and all the loops of the jejunum on the right side. Therefore, this is a classical malrotation. Just one word about the Ladd's procedure, because you need to know an important point about this. The treatment of malrotation is what is called as Ladd's procedure, named after a very famous pediatric surgeon of the yesteryears. It consists of two main points at laparotomy, which can be done at open laparotomy or laparoscopically. The first is these Ladd's bands, which are causing the obstruction, are released, and therefore the obstruction and the vomiting is relieved. The second is the narrow mesentery is widened, and therefore the volvulus is prevented. The two cardinal problems of malrotation, namely intestinal obstruction and volvulus, is prevented by doing these two procedures. But what I would like you to remember is the rotation still continues to be abnormal at the end of the procedure. Why? Because we don't try to control correct the rotation, because if you try doing that, the superior mesenteric artery, which runs through the mesentery of the bowel, will get damaged. This damage to the superior mesenteric artery can result in damage to the entire small bowel, starting from the mid duodenum to the mid transverse colon, and you can get gangrene of an extensive area, as you see it when you have volvulus. So early diagnosis of bilious vomiting in a newborn, you have to make sure that you rule out malrotation and therefore prevent this disastrous condition. A few practical points regarding intestinal obstruction, especially before you transfer the patient, if you need to transfer them. Ensure proper Ryle's tube decompression of the stomach. This is very, very important to prevent gastric distension, vomiting, and aspiration, so that which will compromise the child further. As mentioned by all the speakers so far, temperature maintenance during transfer is extremely important and has to be given proper attention to. Oxygenation levels should be done and should be monitored, especially if it's being transferred long distances. Preparation should be done for intubation if required. And if intubation is required, it is better to do it early rather than late. Transfer early is the dictum. Do not wait for too late for the problems to be escalated before you transfer. Some causes of non-bilious vomiting in children, neonates and otherwise include idiopathic hypertrophic pyloric stenosis or CHPS, gastroesophageal reflux disease, preduodenal obstructions, pyloric antral web, etc. But please remember, non-bilious vomiting can occur in non-surgical conditions also, of which sepsis is very, very important. Just a picture of a hypertrophic pyloric stenosis where the muscle of the pylorus is grossly hypertrophic, causing obstruction at the preduodenal level, therefore having non-bilious vomiting. The diagnostic armamentarium includes barium meal, which shows a narrow pyloric channel, suggestive of hypertrophic pyloric stenosis. But nowadays, a good sonologist is able to make that diagnosis non-invasively quite fast. Vomiting associated with abdominal distension, associated with constipation or with failure to pass meconium. Please remember in mind Hirschsprung's disease and anorectal malformations in the newborn. Have a look at the baby, the bottom especially, because it will be quite embarrassing to note on the day 4 or day 5 that this child has got an anorectal malformation. Other causes of vomiting with abdominal distension and constipation occurs more in adults with intestinal obstruction due to bands, peritonitis, appendicular abscesses, etc., etc. Just a point to highlight to you that Hirschsprung's disease can cause bilious vomiting in a newborn with abdominal distension and with failure to pass meconium in the normal period of time. But what I would like to emphasize over here is that the spastic lower anorectum is the pathological area and not the dilated system. The dilated system occurs due to the non-ganglionated lower system going into spasm and therefore it dilates. The collapsed area is the one which is at fault. Plain X-ray of the abdomen of a child with Hirschsprung's disease shows dilated bowel, but without the airflow levels, or rather soft airflow levels, because this is more of a partial obstruction rather than a complete obstruction. So you may not get the classical picture of multiple air fluid levels when you see a child with Hirschsprung's disease. Barium enema shows the transition zone between the lower anorectum, which is aganglionic, and the dilated ganglionic segment. And this is almost diagnostic of the thing, though the final decision is based on pathological examination of the resected specimen showing no ganglions. Operative picture of the Hirschsprung's disease. This is actually the ganglionic normal segment, which is grossly dilated. Just a few pictures of anorectal malformation. As I said earlier, please look at the bottom of a newborn because you don't want to miss out on this and be embarrassed on the 4th or 5th day by such a diagnosis. We do still continue with the definition of a low, intermediate, and high anorectal malformation because it does have a lot of significance as far as prognosis and long-term results are concerned. Again, just to highlight the thing, Rayleigh tube decompression is very important, temperature maintenance of proper oxygen saturations, and transferring early. Respiratory distress in a newborn. The surgical conditions I would like to highlight are diaphragmatic hernia, esophageal atresia with or without esophageal fistula, Peary-Robin syndrome, coronal atresia, congenital lobar emphysema, congenital cystic adenomatoid malformation. These are some of the more commoner ones, though there are very many more. As everybody has mentioned, I would like to spend a couple of minutes on this potentially fatal and morbid condition, pneumothorax. This can occur due to very, very causes. The problem is that it develops tension very, very fast, resulting in rapid respiratory distress and deterioration of the child. All patients dealing with pediatrics, especially newborns, should be aware of how to do an emergency needle aspiration. Simple procedure, buys a lot of time, and you can save the child while waiting for the final answer, which will be an intercostal drainage tube with an underwater seal. So as just to highlight again, the treatment is immediate drainage with underwater seal. You may, in certain conditions, have to deal with the underlying pathology where thoracoscopy or thoracotomy may be required. Just to highlight again to you all, tension pneumothorax, stick in a needle, a scalpel needle, or into the area of maximum resistance, let out the air as much as possible, avoid the, allow the lung to expand as much as possible. Therefore, you can convert it into a relaxed procedure. In a pneumothorax, the ideal place is to put a second in the second intercostal space in the mid-clavicular line. Hemothorax and empyema, fifth or sixth intercostal plane, anterior axillary line. Respiratory distress with a scaphoid abdomen is usually congenital diaphragmatic hernia because all the bowels have herniated into the chest. At this point, what I would like to highlight is when you take an X-ray for a child with congenital diaphragmatic hernia, please include the X-ray of the abdomen. A gasless abdomen with shift of the mediastinum and air bubbles in the chest is diagnostic of diaphragmatic hernia. If you find the gas loops are in the abdomen, please think of other conditions like congenital cystic adenomatoid malformation, etc. Here again, Rayleigh tube decompression is extremely important because gastric distension, which occurs either because of air hunger or otherwise, can result in much more deterioration of the respiratory system. So no child with diagnosed or suspected CDH should have delay in Rayleigh tube being used to decompress the stomach. Respiratory distress with drooling, think of esophageal atresia with the tracheoesophageal fistula. This is a classical X-ray of esophageal atresia. You can see the upper pouch ending blindly here. But what I would like to emphasize is, please again include the abdominal X-ray, because if you show air in the stomach, it means that this is a classical esophageal atresia with an upper pouch atresia and a lower pouch fistula. The significance of this is that there is a fistula, and if there is a fistula with the lower pouch, we can consider a primary repair. On the other hand, if you do not have gas in the abdomen, it is either without a fistula or it is a pure atresia, in which case the possibility of a primary repair may be difficult. We may even have to talk of staged repairs in such a situation. So please ensure that X-rays of the abdomen is also included. Neonate with jaundice, exaggerated physiological jaundice is well known to you all, so I won't go there. But please think of biliary atresia, developing choledochal cyst, and extrahepatic biliary obstruction. Sepsis is one condition where there is jaundice, and therefore this has to be kept in mind, even despite the fact that surgical jaundices can occur. Picture of a biliary atresia where the extrahepatic biliary entire system is atretic, resulting in obstructive jaundice. Now, the biliary atresia is a very, very difficult place for us to be dealing with because delay affects prognosis. So as a pediatrician, if you do get obstructive jaundice, rising values, please keep biliary atresia in mind and start thinking in those lines. Generally, everybody does an ultrasound as the first investigation, which is a very good investigation. And if it does not show a gallbladder, then please consider biliary atresia high on the list. HIDA scans after priming with phenobarbital are very useful, but remember there are high rates of false negatives. These false negatives can be reduced to a large extent by taking a 24-hour delayed films, but still the gold standard is mini laparotomy and parop cholangiogram, which will confirm the presence or absence of biliary atresia. Early diagnosis is very essential because it results in good results. The treatment of choice is Kasai's portoenterostomy. But I'd like to highlight a point that Kasai's portoenterostomy, where we make a drainage from the liver porta hepatis to the intestine, is actually only a bridging to transplant. This is not the answer in all patients. Definitely some patients do get away with photoenterostomy, but many patients end up with needing progressive failure of the liver, cirrhosis, and needing a liver transplant. Choledochal cyst is, on the other hand, much more better results as compared to biliary atresia. Various types of it, but basically this is an extrahepatic obstruction and a result. Easier to diagnose because both USG scan of the abdomen or a magnetic resonance of the MRCP is very diagnostic with good results. Early intervention has got very good results. Many often these children are without symptoms and this is picked up accidentally, and parents are reluctant to get intervention. But please tell them that both cholangitis and malignant transformation are highly possible, and therefore treatment is mandatory even in asymptomatic children. A child, especially a neonate with a painful limb, where there is no trauma, no signs of inflammation, please keep in mind osteomyelitis, because osteomyelitis can be very subtle. However, it is very dangerous because especially in a newborn, the bone can vanish in a very short while due to the high pressure below the periosteum and resulting in bone necrosis with a lot of deformity and limitation of movement in the long run. Children with UTI is a very big chapter by itself, and I would not like to go into it in detail, except to say that it is extremely important to have this diagnosis made, because 80% of the children with culture-proven urinary tract infections go on to have an anatomical basis for their abnormality. And this abnormality, unless that is corrected, recurrent UTI can result in pyelonephritis, and therefore it is very renal danger to the renal function. 2 culture-proven infections in a female or more than 1 infection in a male should be treated energetically and investigated completely. And as part of investigation, culture-proven taken very aseptically with the proper techniques and proper interpretation is important to make a proper diagnosis and management. Some of the causes of UTI or with or without symptoms include posterior urethral valve, especially newborn, presenting with abdominal distension and dribbling of urine. This is an MCU of a child with a posterior urethral valve. You can see the bladder here, the grossly dilated posterior urethra, the valve area, and a narrow anterior urethra. This is a classical posterior urethral valve with obstructive symptoms. The other causes of UTI in children include vesicoureteric reflux, which could be primary or secondary. This is an MCU showing VUR on both sides. A posterior urethral valve, again, with no VUR, so you do not need to compulsorily get VUR in PUV, or you may get severe one on one side or both sides, depending on the status. At this point, I would like to spend a few seconds to talk about a few important timings as far as surgical conditions of the newborn are concerned. Generally, a newborn should pass meconium in 24 hours of birth. If the child does not pass within 24 hours, please start looking for causes of the failure to pass meconium. Do not stimulate the child unless you have an answer in mind, because once you stimulate the child and child passes meconium, then if it goes back into constipation, we will have to wait an extremely long time before we can make the diagnosis again. Urine, on the other hand, we can wait up to 48 hours because very often they may pass at the time of the birth, and therefore up to 48 hours in a well-hydrated baby can wait to pass urine. Descent of testis occurs at birth, and that is anything which does not occur at that time is called undescended testis, and the significance of that is well known to all of us. Some of the causes of failure to pass meconium within 24 hours include medical conditions like prematurity, sepsis, hypothyroidism, etc. But surgical causes include Hirschsprung's disease and anorectal malformations. This is why if you have a Hirschsprung's disease and you evacuate it on stimulation, We will need to wait for the child to distend again before we take an X-ray and confirm the diagnosis, which will lose valuable time. Delay in passage of urine can occur because of inadequate hydration, but keep in mind posterior urethral valve, agenesis partial or complete of the kidneys, and very rarely bilateral PU junction obstruction. So when you have a baby which needs treatment, how do you and when do you assess them to be referred to your pediatric surgeons? I basically say there are three groups in which these can be categorized. The group which needs immediate surgical intervention, the group which needs intermediate, you can wait for a short while but not indefinitely, and the group which can be electively maintained. The urgent ones include anorectal malformations, diaphragmatic hernias, posterior urethral valves, intestinal obstructions, atresias, malrotation, etc., and very many other causes. The intermediate groups include inguinal hernia. Now, inguinal hernia is one place where I would like to emphasize by saying that we don't need to do it on the day that it is being diagnosed. But because of the high chance of complications occurring, they are what we would call semi or elective emergencies. Do it as early as possible on an elective list. Cleft palate, cleft lips can wait for a few months for the weight to develop. Hydronephrosis, especially if it is unilateral, can wait depending on the function of the other side. Swellings which are suspected malignant need workup before they are taken up for surgery, etc. This is an inguinal hernia, potentially a very dangerous situation if obstruction occurs. So please make sure that you give them adequate guidance to have early surgical treatment. Hydrocele, on the other hand, can wait 6 months, 9 months before we go in for intervention. But beyond 1 year is not, if it is persisting beyond 1 year, definitely not. Undescended testis, again, at birth it is descended, but if it does not descend by 6 months to 9 months of age, we have to start considering it as early as possible after that because the chance of atrophy is very high. Umbilical hernia, unlike the inguinal hernia, has got a less chance of complications. So we wait 2.5 years under close monitoring. Hypospadias, epispadias, generally we say at around 1.5 years because it needs stage repair and you would like to complete the procedure before they go to school. So these are some of the elective procedures. Other conditions that you need to see in a child, surgical conditions that you need to see in especially older child include acute intussusceptions, painful scrotal swellings, acute appendicitis, etc. This is a pneumatic insufflation picture of a child with intussusception. With the advent of ultrasound and with the pediatricians referring earlier, in the last 20 years, I have hardly had to operate on a child for intussusception. I have been able to successfully reduce over 98% of the intussusceptions non-operatively by using a pneumatic technique called pneumatic insufflation, where we insufflate through the rectum air and reduce intussusception. This is a picture which shows the intussusceptum inside the intussuscipiens at pneumatic insufflation. The end point is full small bowel fillings being seen, shows that you have successfully reduced it. I use air, but there are other people who use water. It is fine, both are equally good. A question which many pediatricians have in their mind is, are all abdominal pains significant? Do we have to refer for every pain the moment they come and see you? Not necessarily. Some of the cardinal signs associated with which make it significant are if the child is in significant pain which lasts continuously for 4 hours or more, or if there are symptoms like vomiting, constipation, abdominal distension, then or fever, then yes, they need to be seen as early as possible by the pediatric surgeon. Acute onset unilateral testicular pain with swelling is again a very, very important thing because it could be a harbinger for torsion testis. I'd like to emphasize each word here: acute onset, unilateral swelling with pain of the testis. This features, if there are present, please make sure that you keep in mind torsion tests. The ultrasound and Doppler can be done, but there are high false negative rates in Dopplers. A good flow can occur even in ischemic tests due to revascularization. So it is not the ultimate thing. If in doubt and you consider acute unilateral testicular strain, please ensure that they are ready for exploration. Otherwise, the end result would be infarcted gangrenous testis, and that would be a disaster. Ovarian cysts picked up incidentally should also be kept in mind and should be under good follow-up because they can undergo torsion similarly, resulting in loss of the entire ovary. Therefore, please keep this also, even if they are not asymptomatic, they have to be under close observation. Onset of pain in a child with a known case of ovarian testis. Caution. Sudden choking followed by noisy breathing or breathing difficulty in another otherwise normal child, please think of foreign body. And I always say the mother knows best. If she thinks that there has been an aspiration, you can be almost sure that there is a foreign body in the chest and the bronchi. X-rays may be very, very subtle. It takes time. The initial X-ray may not show anything. So even if you see the child and there are no findings, please ensure that you keep this child under the follow-up for the next couple of days before you are sure that there is no foreign body aspiration. This is what we will see at rigid bronchoscopy when we see for a foreign body, the carina with the left and the right bronchi, and here you see a foreign body peanut in the right bronchus. Foreign bodies could also be in the aerodigestive tract, like in the esophagus, where you have foreign bodies like coins, batteries, etc. These are also very common with our children. One word about genetic antenatal guidance counseling. With the increasing ultrasound and increasing antenatal scans, we do get a lot of referrals for advice about it. So this is very useful from one point of view, is transferring of the patient. Please remember, fetus with abnormality is best transported in utero. The best transport medium is in utero transfer to a place where the fetus can be treated if it is not in the same place. The temperature is there, the baby is well protected in a womb, and so counseling can be all done in a proper way so that these patients can be well aware of what they are going to face after the baby delivers. In addition to what was mentioned earlier, I'd like to just spend one point. When you say genetic sex is both the parents, I would like to also add, please remember, congenital malformations, both parents are there. It is not the blame of any one spouse, because very often this can result in marital disharmony. Rare conditions play by the situation, omphalocele, gastroschisis. Remember, the temperature loss is extremely high. Babies can go into severe hypothermia. So when transferring, please make sure temperature loss is minimized at all. Conditions like these are very rare, and therefore you need to go by the take. This was a teratoma of the face. Sacrococcygeal teratoma, another condition which is picked up very often antenatally. Here the importance is the greater the delay, the greater the chance that this becomes malignant transformation. At birth, these babies are all benign, but by 2 years, they become highly malignant. So early treatment is treatment of choice in sacrococcygeal teratoma. That is a picture showing the resection with the tip of the coccyx, because otherwise recurrence can occur. A huge tumor in a child who was just a newborn, but complete excision and a good result at the end of it. Meningoceles need a lot of counseling because the excision or treatment is not the end of the story. They can have a lot of neurological problems later, hydrocephalus, continence problems, urology problems, etc. So we need to counsel them. Haematomas are again important from the point of view of surgical excision. So I would like to end by just summarizing a few things which I think are very important, which you should know as far as pediatricians are concerned. A baby, neonate or an infant or an adult child will withstand any surgery very well. but they do not tolerate a bad surgeon or a poor quality anesthesia. So these are two very crucial aspects that which need to be maintained, to be monitored when treating surgical conditions. Healing and adaptation in children is excellent. Early treatment avoids undesirable psychological trauma to the child and the family. As already mentioned by many of the speakers, child and the family is part of a single unit, and we'll have to consider them as a single whole, the whole family. Do not separate the children from the mom, especially the younger ones, unless it is essential. So reduce ICU time to the minimum. It's good to complete all elective operations if possible before the child goes to school, so as to prevent social stigmas. Some points I would like you to remember, especially when dealing with surgical conditions. If you are transferring the patient, please call and inform the referring doctor so that he is prepared and his team is prepared to receive the baby. Discuss the case, mention what is the suspected dream, discuss on how it will be proceeded. And I would like you to please remember one thing. Please do not advise about the type of surgery or timing of surgery to them, because it can be very, very disastrous. I have been having a lot of problems with patients landing up here with say foreign body bronchus, which you all know we won't run immediately unless the baby is stabilized, or diaphragmatic hernia. They land up and they expect us to be waiting at the entrance of the emergency department to take the baby straight to the theater. That is not right. Stabilizing the patient is very important. So in this situation, your words carry a weight of gold. If you say the surgeon is waiting for you, the moment you land up there, they will operate, then that is what they expect. And anything other than that can be a disaster. Bilious vomiting, especially in a newborn, please do not let the sun set without ruling out malrotation, because if volvulus occurs, it is a big disaster. Respiratory distress, especially if CDH is suspected, no bag and mask, please. Make sure you have a Riles tube in situ to decompress the stomach. When transferring a patient, please secure the airway, secure IV lines, maintain temperature, maintain hydration, make sure gastric decompression is well maintained. Thus, I would like to end by saying that I have given you enough in a nutshell to make you all into what I would call OPD pediatric surgeons. I don't expect you to operate, but I expect you to make sure that the patient safely reaches a pediatric surgeon of your choice. Thank you very much. Happy Independence Day, and a lovely wishes to all the persons in IAP Wayanad and IAP Kerala. Thank you.
Thank you, sir, for that very informative presentation and advice. Even though it is a very vast subject, you made it very simple and interesting. I think there are no more questions. I just want to add one point in this COVID era. One acute abdomen, which confused with MISC, because recently we had 2 cases of acute abdomen, that is acute appendicitis penetration. Sir may be knowing that. The person that they refer to us as MISC. So be careful because both can be confusing. So you have to be very, very, you have to get opinion from pediatricians, your colleagues before making diagnosis. Thank you very much.
Yes, Dr. Nandakumar, I can remember that case and I agree with you totally. The abdomen is a Pandora's box. We have no special glasses to find out what's happening inside. So we need to be absolutely certain before we decide to operate on the baby, because once you touch the baby, then everything is blamed on that. Thank you very much.
Thank you, sir.
Thank you, Abraham sir, for highlighting a lot of points on what we should do when we encounter a pediatric surgical emergency. Thank you, Nandakumar sir, for chairing the session in an excellent way. We will move on to the...
Sir, I have a question, sir. Can I?
Yes, sir. Please, sir. Yes, please.
Yeah. During this pandemic, you see, when dengue was brought, dengue was there. During the epidemics of dengue, no surgeon would ever touch the abdomen when brought with, dengue with warning sign, the acute abdomen. Do you have ever come across during this period with acute abdomen?
Yes, sir. To tell you the truth, the last 2 years, we've had enough and more acute surgical problems of all types, including appendicitis and acute abdomens. One observation that I had during the first wave was there was a drastic fall in interceptions. When we were doing about 4 to 5 per month, it had dropped to almost 1 in a week or 1 in 2 weeks. That was a very, very obvious striking feature. But thinking back, I feel that because of the use of masks, because of the restriction in social activities and isolation, URI almost vanished from the pediatric scene. And you know, URI is a common cause as a precedent for interception. So probably that is why interception markedly decreased. But no, to the rest of the other things, acute appendicitis, intestinal obstructions, newborn problems, they are all going on as per this thing. We are very particular in dealing with them with COVID protocols. So to answer your question, we still do see a lot of, despite COVID and dengue, we do see problems on a normal basis.
That was a very brilliant explanation, sir. Thank you very much, Abraham, sir. Thank you so much.
Thank you very much. You're welcome.
Thank you, sir. Thank you once again. We'll move on to the last but interesting session on chest X-rays. To chair this session, I invite Dr. Suresh Kumar EK, HOD Pediatrics at Aster MIMS, Kozhikode. Sir is the chairperson of aerosol therapy under Presidential Action Plan 2021. He was the State Secretary of IAP Kerala in the year 2003-2004. Sir, 14. Sir is a true gentleman with whom I have a personal bond whom is spanning 10 to 12 years. Over to you, sir.
Thank you, Dr. Yashwant, for your nice words. And congrats to IAP Wayanad and Monsoon Pedicon Organizing Committee for this very informative CME today. Thanks for giving me this opportunity to chair the session on chest X-rays in office practice for pediatricians by my good friend, Dr. Krishna Mohan. And like other topics, you have witnessed many good topics, many good speakers. And this is also a very relevant topic for all of us. And I am very happy that today we are having one of the most dynamic IAP office bearer and one of the best young speakers in India to deal the topic. Dr. KM, that's how he is popularly known. He is the backbone of IAP Kerala, IAP Kozhikode, and also my personal interest, the aerosol therapy action plan of state IAP president. So he is a pediatric allergy specialist and trained from CMC Vellore, and also got special training in bronchoscopy and tuberculosis from reputed institutes in the country. He is the recipient of Best Academic Activities Award of IAP Kerala in 2016, and he is also awarded Best Doctor Award from KGMOA in 2019. Also, he is the academic editor of Partha's Handbook of Pediatrics and has contributed many review articles and chapters in various IAP journals and textbooks. He is at present the state chairperson of Respiratory chapter of IAP Kerala, and he is the editor and treasurer of National Allergy chapter of Central IAP, and also National EB member of Respiratory chapter. He is the state joint secretary of IAP Kerala now at present, and he was the state chairperson for allergy and applied immunology of the applied immunology chapter of Kerala. He is now working as a consultant pediatrician in Kerala Government Health Services, Kozhikode Taluk Hospital. And with these words, I give the mic to platform to Dr. Krishna Mohan, who will be speaking on X-rays in pediatric practice. Over to Dr. Krishna Mohan.
Good afternoon, sir. Am I audible, sir?
Sir, you are audible, sir.
Audible,
Yes,
your screen is visible also.
Okay. So thank you very much, Suresh sir, for that nice words about me.
Krishna Mohan, sir, excuse me.
Yes,
Could you
yes.
put on the slideshow, sir?
1 minute, sir. Okay.
Thank you.
Okay. Okay, sir. So thank you, Suresh sir, for those nice words about me. Perhaps it was E.K. Suresh Kumar sir who first brought me to IAP. And I am so much happy and excited and also proud to see that my first pediatric teacher, Parvati Madam, is there to listen to this talk. I also thank IAP Wayanad and IAP Kerala for giving me this wonderful opportunity, especially my very dear friends Yashwant and Vishnu and Monsoon sir also. I also thank our dearest Somashekar sir, the National Vice President, he is here. So thank you so much. So today, as Suresh sir mentioned, we are going to discuss in short about chest X-rays. So when Vishnu and Yashwant gave me this topic, I told it is humanly impossible to cover chest X-ray in 20 minutes. So I requested them to give me the last talk so that I can take 10 minutes more. So coming to the topic, this is not a complicated talk compared with the previous talks and all. There are some, we are seeing some complicated cases and all. This will be a very simple talk, and this is about some basics of X-ray. So whenever you are seeing an X-ray, the first and foremost thing is that you have to view it properly. So viewing properly means it starts from how you are holding it. You are not supposed to hold an X-ray. It is a basic. These points may sound very basic, but these are important. This is not a photograph. This is an X-ray. So always use a view box, and always take care that you confirm that the X-ray you are giving is having the proper markings. The side, label, age, everything should be there. And nowadays, even though Suresh sir said that X-ray is very interesting for pediatricians and all, but when radiologists are concerned, it is the least important thing for them, because they are having many fashionable and fascinating subjects like CT, MRI, everything, etc. So very less radiologists have an interest in X-ray itself. So there comes the importance of pediatricians and physicians knowing the X-ray. So when you are analyzing an X-ray, the first and foremost thing is that you have to assess the technical quality. Any product you're getting, you have to make sure that the technical quality by which it is made is good. So as far as an X-ray is concerned, these are the important factors which we have to take care. It should have a good exposure. It should not have a rotation. The respiratory phase in which it is taken is important, and the type of the film. Is it an AP film or a PA film? All these things are important. We will consider one by one. So if you are seeing this picture, so both of them almost look alike. But what is the difference that you are seeing? I wish if it was a physical session, I would have asked some of the delegates so that they would have answered. But what is the basic difference that you are seeing between these two X-rays? It is about the exposure. The one on the left is a normal X-ray, but the second one is a underexposed X-ray. So before going to what is an underexposed X-ray, how will you make sure that it is a properly exposed X-ray? You have to look at the lower part of the cardiac shadow. That is, the criteria is that the vertebral bodies should only just be visible through the cardiac shadow at this point. So if you are seeing with a normal film, you can see through the heart, you can just see the vertebral bodies. But on the underexposed film, you are not, you cannot make out between which is the heart, which is the vertebra, you cannot make out. So here the spine is not visible through the heart. Retrocardiac area, we cannot see any lung markings, and lung fields appear falsely white. So if it is over-penetrated, then the lung fields become very dark. Then we can miss the low density lesions. So both these things, even if it is overexposed or underexposed, both are not good. It should be adequately exposed. But nowadays we have the digital X-rays. This is not much of a problem. But in many of the peripheral setups, even now the old-fashioned X-ray machines are used. So improper exposure, we may miss or we may misdiagnose conditions like pleural effusion, pneumothorax, pulmonary edema, and retrocardiac density. So that is the importance of a proper exposure. Now comes to rotation. Rotation, if you see this picture, both these pictures are of the same child, but the difference is that in one, the film appears rotated. So ideally, we should, when an X-ray is taken, the X-ray film is kept on one part of the body, front of the body, and the X-ray is coming from the back or front, depending on the P or AP view. So ideally, the medial end of the clavicle should be equidistant from the spinous process of the vertebra. That is when we say it is a properly placed or non-rotated field. You can see, so if the medial ends of the clavicle, if it is equidistant from the spinous process, we say it is a properly placed or non-rotated field. Now here you can see a rotated film. So if the film is rotated, there will be an exaggeration of the cardiac size, and also there will be an exaggeration of the color of the film or the quality of the film. Size, shape of the cardiac silhouette and the mediastinum will be distorted. And not only that, if one side is rotated, the lung on that side will appear more wide. So you may falsely diagnose some findings like consolidation or collapse, etc. if you are getting a rotated film. So Sri has taught us the importance of taking deep breaths. But as far as an X-ray is concerned, what is the importance of an inspiratory film versus an expiratory film? So in pediatrics, even though we say that ideally we have to take a inspiratory film at end inspiration, it is very difficult because the child may not be cooperating. So many of times we have to comment on the X-ray which we get. So this is an inspiratory film and this is an expiratory film. So what are the changes that you are seeing? Of the same child, you have taken an inspiratory film and an expiratory film. So what are the basic changes? So before that, what is an inspiratory film? On getting an X-ray, how can you comment that it is an inspiratory film? So inspiratory image is one in which the anterior sixth, or if you are saying a range 5 to 7 rib, or the posterior 9th rib is visualized above apex of the hemidiaphragm. That is, if you see this picture, you can see the markings in light green, 1, 2, 3, 4, 5, etc. So you can see that the 6th anterior rib is just above the right hemidiaphragm. So it is a inspiratory X-ray. So what are the consequences of an inadequate inspiration? If you are taking it in a expiratory film, what are the consequences that are liable to occur? Because the lung volumes can appear falsely low, the lung markings appear falsely prominent. Sometimes you may misdiagnose it as pulmonary edema, and cardiac silhouette and mediastinum may appear falsely enlarged. Even if there is no cardiomegaly, we may falsely diagnose it as having a cardiomegaly. So that is the importance of inspiratory versus expiratory. Now coming to the final one, what is the difference between a PA film and an AP film? Here also, unfortunately, it will be difficult for pediatricians to always order a PA film because small kids may not be cooperative enough for taking a PA film. So we have to compromise with AP film. So this is a PA film where the X-rays are coming and hitting the patient from the back, and the film is kept in the close to the chest of the patient. This is a PA film, and this is a AP film. AP film, what we are seeing is that the X-ray is kept behind the patient. So what is the basic difference when you are taking an AP film and a PA film? So if you are taking a PA film, the X-ray film is close to your heart. So the X-rays, they will be coming almost in a straight line. On the other hand, when you are seeing a AP film, when it is projected, X-rays will be scattered because there is a small distance between these things. So it will be scattered and there will be an exaggerated size of the heart. So you may falsely diagnose a cardiomegaly if you are taking an AP film. But for all other purposes, for the respiratory diagnosis, AP film is well and good, no problem. So how will you identify an AP film? In an AP film, the clavicle will be at a higher position and more horizontal. And another important thing is the scapula. In an AP film, the scapula, the medial border is well inside the chest wall. So you will be seeing the scapula in an AP film. Ribs are more horizontal. And as I told now, heart and great vessels, there will be an apparent cardiomegaly in case of an AP film. So as far as possible, if the child is cooperative, we can take a PA film. But in all the cases, we have to compromise with the AP film itself. Now coming to the next part. From our UG and PG days, everybody used to tell us, you should have a systematic approach in diagnosing and reading an X-ray. So some people will have taught you about outside in, that is, you first look at the soft tissue, then you see the bone, then you see the rib cage, then you come to the lung, like that. Some others will say inside out, that is, you first look at the heart, go outside. So whichever way you are using, you should make sure that you are not missing anything. So this is another system of reading, the ABCDEF system. So after assessing the technical quality, as the 4 points I mentioned, after assessing the technical quality, if you use an acronym like this, there is very less chance that you may miss something. So A is for airways, B is for bones and soft tissue, C is for cardiac cylindrite and mediastinum, D is for diaphragm and the gastric bubble, that is also very important. E is for effusions, and F finally is for fields. There is no compulsion that you should use this thing or you have to follow the same order, but the only thing is that you should make sure that whenever you are reading an X-ray, none of these areas are missed. So you have to see the airways, you have to look for the position of the trachea, you have to see the lung fields incomplete, you have to see there are any lesions, any color change, any collapse, anything, everything you have to see. You have to see the cardiac borders, and you have to see the rib cage as well as the soft tissue. Whichever way you are following, you should make sure that you are not missing anything. Now I start with some cases, some X-rays. So what are you seeing in this X-ray? Is there any abnormality? Is there a mass lesion on the left side? Or is there any mediastinal widening? Actually, it is a enlarged thymus. So when we are seeing pediatric patients, so many a times we will be getting images like this. So the first image is a normal thymus mistaken for widened mediastinum. Sometimes you will get like a prominent left lobe of thymus. Sometimes you get a left-sided thymus. Sometimes you get a wavy thymus, sail sign. All these things are different ways in which a thymus may present in an X-ray. So a few words about thymus. Thymus usually, if you can see in this picture, it is the usual position of thymus, and it regresses with age, and usually in a small child, we will be having difficulty in distinguishing the left hilar because the thymus will be overlaying that, and it can get enlarged. So thymus, even if it get enlarged, it won't cause any pressure effect. It does not have any mass effect on the vascular structures or airways. And the anatomy is that it extends from as high as the lower border of thyroid to the post cartilage downwards. Is there any sound disturbance? Hello? Yeshwant? Is it okay now?
Yeah, it is okay.
Okay. So thymus, as I showed in the previous pictures, if you are getting an X-ray film and if you are suspecting if it is a mass lesion or an enlarged lymph node, and still you have a suspicion in your mind that it is thymus, then the easiest investigation that you can do is an USG. USG will simply help you to delineate whether it is a thymus or any other thing. So before going on to analyzing the X-rays, we should have a basic idea about the anatomy of that area. What is inside the chest wall? We should have a very good idea. So knowing the structures is important. So we should have an idea about the lobes of the lung. We all know on the right side, we have 2 fissures and we have 3 lobes, an anterior, an upper lobe, middle lobe and lower lobe. And on the left side, we have got only 2 lobes. Now I will show you a small video. We just have a look at this, and this is a 3-dimensional video of lung. So an idea of this pattern will help you in further slides. So this is the right middle lobe that we are seeing, and then we can see the right upper lobe. And now you are seeing the right lower lobe. This is the left lower lobe and the left upper lobe. So the importance of this comes when we read the X-rays. The knowledge about how the lobes are placed anatomically in a chest X-ray is very important when we want to localize the lesions. Now, in another coming 4 or 5 slides, what I'm telling you is how the different lobes are kept. So this is the how a right upper lobe is seen. So if you remember the previous video, you should know upper lobe is a anterior structure and it occupies the upper anterior part of the right chest. So in the lateral film, you can see it is placed anteriorly. So now this is the right middle lobe. Middle lobe also is a anteriorly placed structure, and you can see it is very close to the right heart border. So any lesion which is overlying the right middle lobe, so there is a chance that it will obscure or abort the right cardiac border. So that is the importance. So if you are getting a lesion in the lower part of the right chest and the cardiac border is very well delineated, then it is not a middle lobe lesion. Most probably it is not a middle lobe lesion. It is probably a lower lobe lesion. So that is the importance of knowing the anatomical position. So this one which I told now is theorized as something called as the Silhouette sign. So what is Silhouette sign? Two substances of the same density when side by side cannot be differentiated from each other. If, however, they are separated by air, the boundaries will be visible. So it has got two uses. It can localize abnormalities on a film even without a lateral view. Also, just now I told, we can localize where the lesion is in some conditions. The loss of clarity of a structure, such as a hemidiaphragm or a hard border, suggests there is a adjacent tissue shadow. I will show you a picture and you will understand. In this picture, what you are seeing is left hard border is obscured. So as we saw in the video, the left lung has got an upper lobe and lower lobe, and the upper lobe, which includes the lingula also, is anteriorly placed. So lingula is a part of the upper lobe. So if there is a pathology or lesion in the lingula or the upper lobe, it will obscure the left heart border. So if there is a pathology in the, if it is not obscuring the left heart border, it is most likely that the lesion is in the left lower lobe. So that is how it helps us. So here we can see a lesion in the right middle lobe. How can we say that it is in the right middle lobe? Here, the right heart border is obscured. So that is the importance of the Silhouette sign. Now, coming to the anatomical position of right lower lobe. If you remember the video, you can understand the lower lobe in the right as well as left. It is a posteriorly placed structure. So in the lateral film, you can see it is coming posteriorly. And upper lobe, it is appearing bigger than the right side because it includes the lingula. So lingula is almost like a middle lobe which has not fully formed. It is part of the upper lobe, but still it is somewhat separate. It's not like the three lobes in the right side, but lingula is having some separation. So this is how a left upper lobe will look in a PA film and the lateral film. It is a anteriorly placed structure. So this is how a lingula will, the position of lingula is like this. It is also an anteriorly placed structure. As I already told, if there is a lesion in the lingula, the left heart border will be obscured. So this is the left lower lobe. Lower lobes, both sides, they are posterior structures. So in the lateral film, you can see they are lying posteriorly. Now, coming to the cardiac border. This is also very important. What are the structures which forms a heart border in a chest X-ray? The basic idea of this is very important. So, right atrium, right pulmonary artery assembling like this. I will show another picture. So, when you are taking a chest X-ray, left atrium actually does not form any cardiac border except a very small part on the left upper part, which is formed by the left atrial appendage or the auricle. So it forms only a very small part of the left cardiac border. And the right atrium, it is the major constituent of the right heart border, right atrium. Then left ventricle forms the majority of the left cardiac border. And the base is formed with the base means on the right side it is formed with the right ventricle. So coming to these pictures again, left atrium does not form any cardiac border except the left atrial appendage. Right atrium forms the majority of the right cardiac border. Left ventricle forms the majority of the left cardiac border. And finally, right ventricle forms like this. So a knowledge about this is important. The cardiac chamber enlargement and how it is going. So this is a lateral film. In the lateral film, you can see that the right ventricle is the anterior most structure in heart when what you are seeing in X-ray. So in between, this is the sternum and this is the vertebral body. This is the vertebral body. This is the sternum. Heart is lying like this, and this is the right ventricle. So this is this darkest part. This is actually the darkest part in a lateral chest X-ray. This is the retrosternal space. So if this retrosternal space is obliterated, then we can tell that there is something causing a right ventricular enlargement, or something in between which is causing an obliteration. So this is the retrosternal space. Now a few words about a lateral chest X-ray. So lateral chest X-ray, it is not a must that you should take lateral chest X-ray in all patients, but in indicated cases you can take. So this is how a lateral chest X-ray will look. So anteriorly we have this is the sternum, and posteriorly we have the vertebral bodies. And we can see the diaphragm also. Diaphragm, we have the right dome as well as left dome. In a lateral chest X-ray, the right dome of diaphragm can be delineated from the anterior to posterior completely, like this, what you see as number 1. But the left dome of diaphragm, we can see only up to the this cardiac border, only up to that we can see. After that, we cannot see. So the completely delineated part of the diaphragm is the right diaphragm. And this one is the horizontal fissure, and this is the oblique fissure. This I already told. This part is the retrosternal space, and this part is the hilum. So in certain conditions, for example, if you want to exactly localize where the lesion is, then we can take a lateral X-ray. Not necessary always. Now coming to the lung parenchyma. So lung parenchyma, there can be different shadows. It can be homogeneous shadows as well as non-homogeneous shadows. So if it is a homogeneous shadow, it is occupying most of the part of a lobe. It's called a lobar pattern. And if it is non-homogeneous, it can be a bronchopneumonia, or it can be an interstitial also. So these are this is how lung shadows are divided. And we can have different types of lesions. It can be a consolidation, it can be a mass, it can be a nodule, or it can be an atelectasis. And even in a viral pneumonia, when you're getting an interstitial picture, it can be a linear-like or a lace-like or nodular or sometimes reticulonodular. Nowadays, we are getting these COVID cases, and in advanced stages of COVID pneumonia, we get an interstitial pneumonia. Now, we have to localize the lesion. So there is no hard and fast rule that you should follow a particular system. You can either localize a lesion based upon zones, or you can say based upon lobes. So if you are using the zone system, we have 3 zones: upper zone, middle zone, and lower zone. So upper zone, if you see the first blue line, it is a line which is drawn from the apex to the lower border of the anterior end of the second costal cartilage, from the apex to the anterior end of the second costal cartilage. This is the upper zone. And up to the 4th costal cartilage, it is the middle zone, and below that, it is the lower zone. So this is the zone-wise classification of the lung parenchyma, or we can use the lobe-based classification also. As I already told, we have right side 3 lobes and left side 2 lobes. Based upon that also we can tell. Now coming to the different lesions that we see in a chest X-ray. that one of the most important findings will be a consolidation. So what is basically a consolidation? So if we imagine that our lung, its lobes and even the alveoli, if you imagine that it is just like a balloon, it is like a balloon which is filled with air. And in an X-ray, this air will be looking black. That is the picture you can see on the left side. Suppose you are removing the air and replacing with either an edema fluid, blood or pus, then you get a opaque balloon with a normal volume. That is what you see in a consolidation in an X-ray. You get some opaque shadows. Now coming to the localization, you have to remember the video as well as the pictures I showed, which will help you to localize. So where is the lesion here? You are seeing the lesion on the right upper lobe. So it is a right upper lobe consolidation. Here you are seeing a lesion on the right lower part, but you just see the cardiac border. Here the cardiac border is obscured or is averted. So using that Silhouette sign, you can say that it is probably in the right middle lobe. And this lesion is a right lower lobe as well as middle lobe. You cannot see both the hemidiaphragm as well as the right border of heart. Both are these obscure. So it is both a consolidation involving both the middle lobe and the lower lobe. Here, what is the diagnosis? It is a left lower lobe pneumonia. Why it is a left lower lobe pneumonia? Why it is not a left upper lobe or left lingular pneumonia? Because we can very well make out the left cardiac border. If it was a lingular pneumonia involving the lingula, then it would have obscured the left heart border. If the left heart border is clearly seen here, so it is a left lower lobe pneumonia. So this is a bronchopneumonia where you can see the reticulonodular pattern. Now coming to collapse. So collapse, you analyze this picture again. As I already told, lungs, the lobes and even alveoli are filled with air and which appears black in a normal X-ray. Suppose this air is removed and not replaced with anything, then you get a opaque balloon with decreased volume. That is when we say collapse or atelectasis. So you can see the more notable thing is that it has become opaque as well as there is a definite volume loss here. Now coming to the different signs, there are direct signs as well as indirect signs to say that there is a collapse. So what are the direct signs? In the direct signs include, there will be a displacement of fissure, there will be a tracheal shift, and you can see a sharp margin ending in the hilum, and the collapsed area will be showing a increased radio opacity. And the indirect signs include a hilar displacement because there is a volume loss in that area, so hilar will be displaced to that area. There will be elevation of diaphragm above, and there will be a shift of mediastinum, and sometimes there will be a compensatory emphysema also on the opposite side. So these are the direct and indirect signs. So you will understand this when we analyze the pictures. So what are you seeing in this picture? What is the diagnosis? So here what you can see is that this is the horizontal fissure or minor fissure which is shifted upwards, and there you can see an opacity here. You can see a triangular opacity here with the apex pointing towards the hilum. So this is what? This is a right upper lobe collapse. On lateral X-ray also you can see that. So if you diagrammatically represent, it will look like this. So you will get a triangular opacity pointing towards the hilum. Okay, so lateral view not necessary. Only when you have a diagnostic doubt, you can proceed with the lab. So this is the diagrammatic representation how it will look in this BA and lateral X-rays. So this is also a right upper lobe collapse. Now what is this? So what are the findings here? Here you can see the minor fissure or the horizontal fissure. It is pulled down, and here you cannot clearly see the right heart border. So the right heart border is obscured or silhouetted, and the minor fissure is pulled down. Also, you can see, when you see here, the right dome of diaphragm is pulled upward. So there are three findings here. So what is the diagnosis? So diagnosis is a right middle lobe collapse. So right middle lobe collapse, when you see in a lateral X-ray, the finding will be like this. So the one you are seeing in the black arrow, that is this one, this point. This line is the oblique fissure, and the red arrow is showing the horizontal fissure. So this is pulled down, and the oblique fissure is pushed up. So what happens is that you get a slit-like pattern like this. So this is the finding of right middle lobe collapse in a lateral X-ray. If you are seeing it in a diagrammatic form, you can see this is the PA view. Here, the collapse obscures the right heart border, and in lateral X-ray, you will get a slit-like pattern like this. So that is right middle lobe collapse. Now, what is this? Here, you are getting the lesion is on the right lower border of the lung, right lower border. But is it in the middle lobe? No. Why? Because you can see the right heart border very clearly. You can see the right heart border clearly. On the same time, the right dome of diaphragm cannot be clearly made out. So something is obscuring the right dome of diaphragm. So what is the diagnosis? So it is a right lower lobe collapse. So this is a left upper lobe collapse. What is the finding here? Here, where is the lesion? Here you cannot make out the left heart border. So I already told, if there is something which obscures the left heart border, probably the site of the lesion is in the lingula, or the left upper lobe. The lingula is a part of the left upper lobe. So this is a lingular collapse. What is this? So here you can see the left lower lobe is collapsed. So there is every possibility that this may be missed. Here you are supposed to see behind the heart. If you look clearly, what you can see is that in the red arrow, there is a triangular opacity behind the heart. And in the lateral film, you can see another triangular lesion over the vertebral column. So this is a collapse of the left lower lobe. So if you see it in a diagrammatic form, it is like this. And until and unless you look carefully for this, you will miss this. So this is what is the diagnosis of this? This is a total collapse of left lung with shift of mediastinum and compensatory hyperinflation. You can see the rib spaces on the right side has widened. That is a hyperinflation. Now, a few slides. I will finish in another 5-10 minutes. Few slides on pleural disease and some mediastinal lesions. So, pleural effusion nowadays not very common, except associated with dengue and all. It takes about 200 to 300 ml of fluid before it comes visible on a chest X-ray. And if you are getting a total opacification of a hemithorax, there will be 5 liters of fluid. So that is about pleural effusion. You are looking for the costophrenic angle, which will be obliterated here. And if you are suspecting a small pleural effusion, then you can take a lateral decubitus view. So what is lateral decubitus view? So, this is how a lateral decubitus X-ray is taken. Here, this is actually this is a PA film, not a lateral X-ray. Because in a lateral X-ray, you are projecting the X-ray from the side of the patient. Here, the patient is lying down, and you are projecting from the posterior part or from behind. You just want to make sure that the minimal amount of fluid which is there is getting accumulated. So even 5 to 10 ml can be detected if you take a lateral decubitus X-ray. And that is about this collapse, consolidation, etc. And before you stop, you should make sure that you are not missing these points. These are certain points where you fail to detect something because you may be missing your some findings here. So always make sure that you analyze the apical zones, hilum, behind the heart, that is the retrocardiac zone, and zone below the dome of diaphragm, as well as the peripheral lung margins. So this is very important. Now coming to another 2 slides about mediastinum, because when you are discussing about chest X-ray, mediastinum lesions are also important. So all of you know there is an anterior mediastinum, posterior mediastinum, and the middle mediastinum, which is the heart is in the middle mediastinum. So what are the different mediastinal structures? Depending upon the position, can be different structures. So for example, in the anterior mediastinum, if you are getting some lesion, it can be lymphoma, thyroid, thymus, teratoma. So this is one situation where a lateral X-ray will help you. If you are getting a mass lesion in the PA film, and if you are suspecting, if you are having a doubt whether it is in the anterior mediastinum or in the posterior mediastinum, then a X-ray taken in the lateral position can help you. So that is in short about my presentation. I have tried to cover some points only because within these 30 minutes, it is impossible to cover everything. So what are the take-home messages? So first and foremost, as I already told, systematic approach in interpreting chest X-ray is a must. Systematic approach doesn't mean that you have to follow what is written in the textbook. You develop your own systematic approach. The only thing is that you should not miss the findings. Good knowledge of anatomy helps to interpret images. That is also very important. And good knowledge means basic knowledge. And number 3, I'm not telling the number 3 now. I will show you a picture, an X-ray picture. You just have a look, make a comment, and then I will come back. So this was an X-ray which I took in my hospital around 5 days back. So are you finding anything in this X-ray, or is it normal? Any obvious finding, or is it normal? This child was 11-year-old girl who is having a recurrent respiratory infection from the age of 2 years. Only one history of hospitalization in between. So this X-ray, obviously there is no some striking features. It almost appears normal. I discussed this with the radiologist also. He also told it is normal. But considering the history, it was a chronic history along with the findings in the clinical examination. She was having a persistent crepitations of the right mid-zone area. So this thing, a CT was done. You see the date. It was taken on 10th of August, only 5 days back. So it was showing bronchiectasis, that too bilateral bronchiectasis in lungs with evidence of secondary infection with endobronchial spread. And actually, I don't know the exact diagnosis. I have sent this patient to MIMS itself, the Department of Pulmonology. I think Suresh sir may be knowing the diagnosis. They didn't come back after that. So the third point which I want to convey is this: always correlate clinically. History and examination is the most important thing. History-wise, this patient, she was having, the mother was telling repeatedly, she is getting repeated infection. We are fed up of that. And examination, reputation. So history and examination is the most important thing. And X-ray is only having a supportive role. And beyond that, one more point, in some situations, we have to proceed further and we have to do the advanced investigation like PCT or MRI. So that is what I have to convey in this small talk. I am sure I know that it is a very small talk and it's a very basic thing, but in these 25 minutes, it is impossible to do more. Thank you so much. Suresh sir.
Congratulations, KM. It was an
Thank you,
academic
sir.
piece.
Thank you,
As expected, you did a wonderful job by from basics. You did a very good teaching job. Actually, we all refreshed our memories and we learned many new things from you now.
Thank
And
you,
as you already mentioned, X-ray is very difficult to interpret most of the time because all these are all typical scenarios which you described. and where you actually we can sometimes you get a combination of findings in X-ray. So most of the time it will be confusing. But this type of guideline is very important when you read an X-ray, and reading how to read the X-ray, how to clinically correlate it. Because sometimes I had experience like somebody was sending me just an X-ray picture, and that also taken a photograph of the X-ray like. So we cannot actually interpret an X-ray like that without clinical history. If you try to interpret an X-ray, that will be disastrous actually. So very, very interesting talk, KM. As expected, you did a wonderful job. If anyone has any questions, I think we can give 1 or 2 questions if organizers agree, or it's already late, 2:15 now. So we wanted more from KM, but time limit is there. So anyone, anything, Dr. Yashwant, can we allow?
No, sir. Actually, there are no questions in the chat box. Everybody is congratulating KM sir for an excellent presentation.
Thank you, sir. If Parvati madam is there, or she left, I don't know.
Yes, it was an excellent talk, Krishna Mohan.
Thank you, madam. Thank you.
It was an excellent talk. Nice
Thank you,
seeing you.
Madam, we charge it.
From basics to the, and everybody usually see X-ray like this showing just like a photograph that you have emphasized. It's very good.
Thank you.
Where was the crepitations in the last X-ray?
Last X-ray, actually the crepitations was on unilateral only. I got it on the left side only, in the subscapular region. But on taking the CT, findings are there bilaterally. But the thing is that it was seen by a physician, and he also told he was getting the same crepitations. Every time she's coming, she was getting the crepitation.
Okay.
That is why we took a CT.
Krishna Mohan, stop sharing so that we can see everybody on screen.
Okay.
Everybody on screen.
Okay,
and one thing I should acknowledge that you took me to our golden days, like where we had our ICH experience. I think Jairam and everybody, Narayan here, that Elizabeth madam used to, post-admission, we used to discuss the X-rays along with, we have to present the cases and the X-ray will be presented. So many things we missed in the ward, like in the night hours, will be brought out by the X-ray discussion. Like that, you took me to 90s, early 90s, in fact, when I was doing my post-graduation. So such a very brilliant presentation, Krishna Mohan. We enjoyed thoroughly. I enjoyed thoroughly.
Thank you, Krishna Mohan sir. Once again, the choice of photos and your presentation was a visual and oral treat. Everybody will agree in this presenting today's platform. Thank you, Suresh sir, for chairing the session in a perfect way and also for being there till the end. Anybody wants to add or wants to comment? We can have it for 1 or 2 minutes and we'll wind up the session. Vishnu Mohan sir.
Yashwant sir.
Yes, sir.
KM, it was really wonderful. Thank you very much.
Thank you, Vishnu.
Thank you.
Shall we wind up the session, sir?
So we'll wind up.
At this juncture,
yes, sir.
At this juncture, as a South Zone VP, I'm vested with the interest of inviting the invited faculties to be a champions of early child development to be held on Cochin, to be held on 5th September Sunday at the Cochin IMA House. I think the Cochin branch, the President Pramod and the CG and the other Guinea, everybody is making the arrangements for, on behalf of the organizing team of the Kochi hosting branch. I welcome you all, and please part of the ECD TOT and be a champion of ECD, Early Child Development, which is one of the flagship program where we need to train 10,000 pediatricians across India. Thank you very much.
It was indeed an academic feast with experts sharing their vast experience with the audience. Before winding up the program, I wish and hope we will encounter ourselves physically in upcoming conferences. Thank you all. Have a great Sunday.
Thank you very much.
Thank you very much, sir.
Jai Hind, Jai IAP.
Jai Hind, Jai IAP.
Vande Mataram.
Okay, sir. അതെ മനോജ് സാർ സംസാരിക്കാൻ വിളിച്ചു കിട്ടുന്നില്ല. മനോജ് sir.
Hi, Yashwant.
Sorry, sir.
Good afternoon. It has been a very wonderful day and a very, very enjoyable Sunday and an Independence Day. First time in life that we are having such a feast, and that too an academic feast with a lot of basics, very well-selected topics, basics, what you should be knowing, what you should be doing, and what you should not be doing. It has been so excellent, all the topics and all the speakers. Wonderful and a very good job done.
Thank you, sir. Thank you very much, sir. Thank you very much, sir. Madhu sir, Johnny sir, anything, last comments? Vijayan sir. Okay.
Excellent session, Yashwant. Thank you, team Wayanad.
Thank you, sir.
For organizing and for the meticulous topics.
Yes, sir.
Each session was an eye-opener. Thank you.
Thank you, Johnny sir. Thank you, sir. Vijayan sir.
Well done, Yashwant. Well done.
All
Congrats.
were
excellent. Sir, sorry. Excellent talks.
Okay, sir. Thank you all, sir. Thank you for sparing Sunday with us. Thank you all. Have a great Sunday.
Thank you all.
Bye, sir. Thank you.